we're going to be talking about the maternal suicide report, and we're going to hear from Christine Morton and Diana Ramos. Christine is a medical sociologist in the Division of Neonatal and Developmental Medicine in the Pediatrics Department at Stanford. In her role at the California Maternal Quality Care Collaborative, she researches maternal mortality and morbidity in collaborates, excuse me. This was unexpected that I'm talking up here, so I'm talking super fast. But you guys will hear from Christine, and then Diana is a well-recognized national public health expert, a board-certified OBGYN and adjunct assistant clinical professor at the Heck University of Southern California School of Medicine.
It's my pleasure to be here to present the work of a whole team of reviewers and members. You'll see that towards the end of the presentation. But I'm going to be going over the prevalence of maternal suicide relative to other causes of maternal mortality. We're going to learn how often the California Review Committee determined maternal suicide could have been prevented, and also identify strategies for preventing maternal suicide. So really, one of the statements that stuck out from this morning to me was from the Alexis Foundation, and that was helping moms is helping families. You know, and really, if we keep that in the back of our mind when we're hearing all of this data, we're going to realize that we really have an opportunity to help moms going forward. So we'll start with some key definitions first, and that is, this is really important because this is the language that you're going to be hearing all of this data being presented in. And the first one is pregnancy-associated death, and this means a death of a woman while pregnant or within 1 year after end of pregnancy from any cause. So not just because she was pregnant, it's from any cause. The next term is pregnancy-related death, and that is death of a woman while pregnant or within 1 year after end of pregnancy from any cause related to or aggravated by the pregnancy or its management. So this is where pregnancy does come in. And then there's accidental death, which is clear indication that self-harm was not intentional, based on either a series of events leading to death or toxicology reports. And then suicide, which is a death caused by directed injurious behavior with an intent to die as a result of the behavior. So keep those in the back of your mind, and now you're going to have the language for which to interpret the information. So we'll start first with what the California Pregnancy-Associated Maternal Mortality Review is, or PAMR. And PAMR is an activity that many states are striving to establish in their own jurisdictions. And California was one of the early innovators and adopters of the Pregnancy-Associated Mortality Review. And we do this to aim to reduce mortality among pregnant and postpartum women up to 1 year after the end of pregnancy. Now, this is done through deep case reviews. And the case reviews of the maternal deaths are really looking at opportunities to improve causes of death classifications and the timing, determine whether the death was related to pregnancy and the degree of preventability, examine social determinants of health to address health inequity, identify multidisciplinary quality improvement opportunities, as well as produce recommendations for preventing deaths in the perinatal population. Now, as I mentioned, we've been doing this for several years, and in my opinion, this is one of the reasons why California has done so well overall nationally in terms of decreasing our maternal mortality. Because when we started, we actually went through this review and took action and developed toolkits and brought a lot of attention to opportunities for improvement. And you'll see that model followed here at the end. So let's start with some basic overall numbers. So in the US and California, looking at the suicide rate overall among women of reproductive age 15 to 49 years old. And this is looking at data from 1999 to 2016. And you may ask yourself, why is it so broad? Why so many years? Well, because suicide is thankfully not that common, but it is, you need to look at a good number in order to appreciate the trends, and that's why you see that. Now, you can see here that in California, the average rate of suicides was 4.7 per 100,000, but look at the U.S. overall, and that's the top line, and that rate is 7.2 per 100,000 in 2016. You can see that the trend is increasing in the United States, but compared to California, we're more or less, at that steady rate with an average of 4.7 per 100,000 deaths, suicide. So what are some of the causes of the pregnancy-associated mortality in California? Now, these are deaths while pregnant or within 1 year after the end of pregnancy. And this is looking at data from 2002 to 2012. Again, these are not that common, and the events are not that common, and that's the reason why we look at a larger span of time. And you can see here that the 65% of the pregnancy-associated mortality was due to medical causes. But more specifically, if we look at suicide, which is what we're going to be reviewing here, that rate was about 4.3%. So deaths by suicide call attention to an unmet maternal mental health need, so 4.3%. We, as a state, have been very good in conjunction with the California Maternal Care Quality Collaborative and CDPH and several partners throughout the state to address the other medical causes of death. And now it's an opportunity for us to start addressing the suicide rate, the 4.3%. So a moving average of suicide ratios for California women of reproductive age from 2002 to 2012, we can see the top line, that is the non-pregnancy associated. So these are suicides in women who were not pregnant, and then the bottom line is the pregnancy associated. And you can see that overall the trend is about starting out at 1.2 for the pregnancy associated up to 1.8 in 2012, compared to the non-pregnancy associated suicides in women of reproductive age. That is averaging about 5 or so, and that's the top line. But why focus on the pregnancy-associated one? Well, if we think about what happens during prenatal care and postpartum, women are not only seeing the obstetrician, but they're also seeing the pediatrician. We heard earlier from our presentations that the pediatric visits are actually an opportunity to address maternal health. So there's about an average of 20 visits during that first year when a woman is pregnant to postpartum, that there could have been an opportunity for somebody to have done an assessment, an intervention if there was suicide or depression risk factors that were present. So that's why we need to focus on this opportunity. Now, looking at the actual numbers of the cases that were reviewed, we can see that the total number of deaths that were reviewed were 99 deaths by suicide. So how did we come to this number? This number was based upon the death certificates. So initially, 86 suicides were designated on the death certificate as being suicide, and upon review, the committee reviewed them. 85 suicides out of the 86 were identified as truly being suicide. So 99% of the deaths were based on death certificate, were confirmed to be a suicide. Now, the other death certificates that were reviewed were those that were accidental or death due to other causes, and those were 31. When those were more closely reviewed, 14 were identified as being suicide. So if we just looked at the suicide, at the death certificates, we would have missed those 14 suicide deaths. So this really is important to highlight the fact that reviewing the cases, pregnancy-associated maternal reviews are really a critical piece in getting the data more accurate. So an in-depth review process really can give us a more fuller understanding. So now let's start to look at the average of pregnancy-associated ratios for California women by data source. So we talked about the death certificates as being a source for identifying suicides, and that's the bottom line. That's the one that ranges from 0.6 to 0.9. The middle line is one that is highlighting data that is obtained through administrative data. And the top one is the one that is actually the PAMR committee review data. And you can see that the top line, really, the trend is much higher overall when you're looking from 2003 all the way to 2012. Again, highlighting the fact that when you actually review with the team, looking through the details of maternal deaths, you actually get a more fuller understanding of what really happened. Now, what about the suicide ratios among women, California women of reproductive age, by race and ethnicity? We oftentimes hear how there's disparities by race and ethnicity. Well, there are some differences in findings here as well. Hispanic women had the lowest suicide ratio compared with other racial ethnic groups in the perinatal population and the general population of reproductive age women who were not pregnant in the prior year. So Hispanic women have the lowest rate. Now, it's important to remember that really in California, close to 50% of all the births now are to Hispanic women. So if you're looking at the big picture, this could be a good thing, right? But there's an opportunity for improvement in looking at the rest of the population. In the perinatal population, suicide ratios were similar among white, black, and Asian women. However, in the general population, the highest suicide ratio was among white women. Okay, so this is an opportunity for us to pay attention and to really intervene. Now, you may be asking yourself, well, what are some of the reasons for the differences of the racial and ethnic disparities? We're not sure, and we don't know. But I think going forward, together through our interventions, and when Christine highlights some of those recommendations, you may hopefully give us some more insight as well. So now let's look at some more in-depth findings on the suicide cohort. So these are more demographic information on these 99 pregnancies that were reviewed. So we can see here that the age of the women who committed suicide in our cohort were pretty much similar in distribution compared with the California birth cohort. And in general, the women who committed suicide tended to be younger than the women in the non-pregnancy associated cohort. So really there's no big difference compared to the general cohort. In terms of education, again, they were pretty similar, but it's important to note and highlight that approximately 1/4 had a bachelor's degree. So what does that mean? That means that no one is immune from depression, from suicide. Just because you have a higher education, higher education can be protected from some other medical conditions, but not here. So unfortunately, we have to pay attention to everyone, and it's an opportunity for us to focus on everyone. There's no discrimination there. Now, other demographic characteristics, too, to be aware of is that the women who committed suicide were, the majority, 77%, were born in the U.S. They were adolescents at the time of their first birth. And more importantly, they received less than adequate prenatal care during their most recent pregnancy. So again, going to have that prenatal care, having access to a healthcare provider, to a system that hopefully could identify risk factors, that was missing, and that was identified as a difference compared to the California birth cohort. And you can see, too, that approximately half were Medi-Cal recipients, and this was similar to the women in the California birth cohort. Now, in terms of timing of death, so when women did commit suicide, 80% of the suicides occurred more than 42 days after their pregnancy ended. Okay, so this is really important to consider, because when we stop to think about the postpartum visit, if they go, it's 42 days. And if they only had emergency Medi-Cal as their healthcare coverage, it ends during the vaginal delivery, if they had a vaginal delivery, at 42 days. So the majority of these deaths occurred after. So what does that mean? Well, if you don't have health insurance, we really have to start to identify and realize, wow, okay, we need to make sure that that mom is okay, especially if there is a history. We need to make sure that it's the community, the father, everybody who was surrounding that mom is there to help her, because we know from our data and from the study that over 80% of the suicides occurred during that time. So how did it happen? And the gentleman from the Alexis Foundation, this really struck a chord with me when he mentioned, how his wife committed suicide. Well, you can see here, 39% was hanging, then it was drug overdose and firearm. So why even address these? Well, it would be prevention opportunities, but unfortunately, as we heard from his story, when somebody is determined to commit suicide, no matter, how much we try to prevent, unfortunately, the suicide is committed. But for us to know what the opportunities are, if there is a firearm that is present at home, if there is medication, to be able to say, okay, let me put this away, let me get this out of the home, or just really be supporting that patient. Now, in terms of mental health history, so you may be thinking, well, maybe this was the first time that the mom had a mental health issue, and that's why she committed suicide. Well, over 60% of the California pregnancy-associated suicide had some type of mental health condition prior to pregnancy. So what does that mean? That means when we have patients that have a history of mental health issue, we really need to pay attention and to provide that support to them. 25% had new onset mental health conditions. And you can see here the range of the various types of mental health conditions prior to pregnancy. 40% of women had a prior suicide attempt. That's really important. Sometimes in the medical chart, they will indicate that. History of suicide, history of depression, history of suicide attempt. So we really need to be vigilant when we come across that information and we're taking care of those patients. And 67% of those suicides occurred within 6 months of death. So really important to help and be vigilant. Now, the mental health diagnostic impressions were also assessed by the committee. And so what this means is, based upon all of the reviews that were done by the committee, a guesstimate likely clinical diagnosis was made, right? This is a retrospective diagnosis that was assumed to probably have been present. It wasn't a clear diagnosis, but you can see here the range of mental health conditions that were most likely present, and that was depression being the highest one at 56%, substance use disorder at 32%, psychosis at 24%, bipolar, you can read on. But really important to highlight that substance use disorder was present 32% of the time. And many times we start to ask ourselves, is it the fact that the substance use disorder is the way that the mom is trying to help cope with the mental health conditions? Or, they oftentimes are happening concurrently. Now we can actually put these into two buckets. And the two buckets of the mental health diagnostic impressions or the more than likely clinical diagnosis can be put into a psychosis bucket or a mood disorder bucket. So the mood disorder, there were 58%, and the psychosis, there were 26% overall. But again, I want to highlight the fact that 16% of those with psychosis had a substance use disorder diagnosis as a probable diagnosis, and those with a mood disorder, 38% had a concurrent substance use disorder. So less than half of the women with serious mental health condition received psychiatric treatment near the time of their death. This is really important, even though there were probably already pre-existing conditions. This is our opportunity to really intervene to address the issue. Now, what about communication? We heard earlier from today that many times patients are calling out for help. Patients are saying, I don't feel right. This is completely different. Well, we know from our reviews that over half of the women expressed at least one type of suicidal communication. Over half. Wow. And so the suicidal communication was verbalized emotional distress in 62%, and these indicated depression due to financial problems, giving the baby up for adoption or foster care, ending the relationship with the partner. We heard earlier today that that was one of the speakers' experience. There was also suicidal ideation and verbalized a suicide plan. So this is really important to listen to our moms, listen to our patients. In the California Pregnancy Associated cohort, the majority of women had suicidal communications noted within 3 months of death. Okay, so all the women that we reviewed within 3 months, they had talked about suicide. And what about reproductive loss? Well, in looking at the women, there was nearly a quarter of women who had a reproductive loss in their most recent pregnancy. Now, over half of the women in the cohort experienced a pregnancy infant loss or a social reproductive loss, and nearly a quarter had a reproductive loss in their most recent pregnancy. And many times we think, well, it's just a miscarriage and, you know, the patient is okay, it was early on. No, a pregnancy is a pregnancy is a pregnancy. And it's something really important for us to realize and to pay attention, because there's been hormonal changes, there's been emotional connection that has already happened, and we need to really accept all of the pregnancies as a pregnancy, even though it may end up in a miscarriage. And in terms of substance use, you know, I mentioned this earlier, nearly all women with a substance use disorder had an overlapping mental health condition. This is really important for us to pay attention. Again, is it the fact that it's the mental health disorder that is driving the substance use disorder as a way of coping? And sometimes that may be an acceptable way if it's an alcohol use or marijuana use now because it's legal. And you can see here in the numbers that are broken down, 32% had illicit drug or abused prescription opioids with or without alcohol. 7% had heavy alcohol use, and 10% had tobacco or marijuana use only. So women who used illicit drugs or abused prescription opioids were more likely to have experienced physical or sexual violence as children or adults. 54% versus 7%. This goes back to the ACEs. We were talking about this earlier. This is also critical when we're addressing and taking care of our patients, to make sure that we include an ACE screening in there so that we can understand where they are coming from. And it's important to note that over 50% of the women did not use any substance. And in terms of stressors, psychosocial stressors near the time of death, approximately 85% of women who died by suicide while pregnant or within a year of pregnancy had one or more psychosocial stressors documented. And you can see, they range from interpersonal conflicts, substance use, financial hardships, exposure to violence, reproductive loss, death of a loved one, housing issues. So, a lot of these are social determinants of health that we're talking about. So they all go hand in hand, the ACEs, the social determinants of health, the mental health issues, the substance abuse. It starts to all interweave and become one issue of unfortunately, a continuing problem that impacts not only the mom, but the whole family. So the review committee determined that stressful life events precipitated the deaths of at least 65% of women. So to summarize the findings for the data portion, some of the big highlights are that suicide is a complex interplay and outcome of biological, psychosocial, and environmental factors. And by reviewing the cases that the committee reviewed, the big takeaways are pre-existing and new onset mental health conditions are there, and 62% have pre-existing mental health condition, 25% have a new onset, 85% had stressful life events near the time of death, potential coping mechanism, 39% used illicit drugs, abused opioids or alcohol, and 24% of women had a pregnancy loss or had a child removed from them. And there was also 83% a lack of support after pregnancy, because 83% of the women died after the 42 days and up to the 1 year after delivering a baby. So lastly, the California PAMR methods led to a more complete and accurate identification of suicide cases. The death certificate is not enough. Really, by doing the intense case reviews, we actually got more richer data and richer opportunities for us to intervene. So I'm going to turn it over to Christine, who's going to take us to activities on what they can do. Do you want me to read over? Yeah, sure.
You can read this in the report. All of this information that we're showing you today is online at the CDPH MCAH website. It's also available at cmqcc.org website. So don't have to take too many hard notes. I get, I guess, the opportunity to talk about the preventability factors. And as Diana earlier on noted, the really importance of those definitions, we grappled as a committee with how to describe a pregnancy or a suicide to a woman who was pregnant in the year prior. How do we identify that as pregnancy related? What are the criteria that we use? The criteria that we use, and we look at medical deaths, was the pregnancy or its management aggravated? Would the woman have died had she not been pregnant, is kind of another way of putting it, okay? So we have that in the first criteria. Underlying mental health issues were aggravated by pregnancy or its management, right? Women not getting treatment, women not being asked whether they had a prior history, getting the wrong kind of medication, or in the pregnancy just further complicating what was already a fairly complex mental health history, right? And then we added some new criteria because we felt these were really important and unique to pull out. The severe postpartum depression, psychosis, or other conditions unique to pregnancy was something that we found that didn't really fit in criteria 1, but we made that criteria. We added one related to pregnancy loss or neonatal loss because we saw this theme of reproductive loss throughout many of the women's histories. Unwanted pregnancy, and then within 42 days, but we couldn't apply any other criteria. That was usually because we had very little information on that person's case. Sources of information included the coroner's report, birth and death hospitalization records, if they were there. Sometimes we got psychiatric records, often we did not. And with most deaths occurring 42 days or more, how could we make a connection between the pregnancy or its management being related to that suicide? It was really, really tricky and complex. And at the end of the day, although we did look at this and we found that the deaths that were pregnancy related by these categories here. Where's the light? Oh, here it is. Okay, right. So the women of the pregnancy-related deaths, we thought, okay, the suicide was related to the fact that she was pregnant or postpartum. 36% of those were in this first category, severe mental health. So, and among the not pregnancy-related, that was half of the cases. Because this woman, largely these were cases where women had longstanding complex psychiatric histories that predated the pregnancy, and by the time the death occurred, it was unclear what the relationship of the death to the pregnancy was. New onset mental health condition was another really important point that we learned here, that this happens, and 38% of the pregnancy-related cases were in that category. As opposed to just 6% over here. And, for the women for which we had no mental health history at all, it was hard to tell, and we usually erred on the side of not pregnancy related. So when we assess the preventability of these deaths, We wanted to ask, was the death preventable? Could some other feasible set of actions been taken that would have changed the outcome? What was the degree of preventability? We looked at a range of strong, good, some, or none. And what were the alternative actions that we might have taken that could have prevented the outcome? And we call those quality improvement opportunities. The committee, kind of in a philosophical sense and also then in an empirical sense, really decided that suicide at its heart is a preventable cause of death. The half of deaths that were considered strong and good, you saw the intersection of those deaths in the pregnancy-related cases. The pregnancy-related cases were more likely to have been deemed preventable. And the cases where there was some chance to alter outcome were, again, in these medically and mental health, psychologically complicated histories where there had been many efforts, or in the opposite sense, there would have been, there were cases where there seemed to be no support, no care at all. You can see here, for women who had been diagnosed with a severe condition before pregnancy, there was a good to strong preventability in 47% of those. And not quite as high because, again, of the complexity of the case, the histories, and the data that we had. For women who were deemed to have had a mild to moderate mental condition before pregnancy, there was very high preventability. Prior suicide attempt, now there were only 4 of these, and this was the only kind of record that we had of this woman's mental health. But it was prior suicide attempt and no information on anything else. And those, again, were some to none. New onset mental health condition, this is largely where the cases with psychosis was, and we all found those to be extremely preventable. And in the 8 cases where we didn't know, it was kind of half and half. So you can probably come up with these opportunities on your own just from having had a tour, if you like, through this data. But we really looked carefully at a lot of the gaps that came out in the stories we heard today, the lack of intersection between obstetric care and mental health care. And it wasn't always clear in the medical records that we had in pregnancy whether or not that woman had been screened in her prenatal care. And as we saw with the data earlier, the coincidence of substance use, is an important factor to consider when we think about how do we treat moms in labor who may be tested positive for a substance, and which kinds of substances are on the panel, that get tested. And as Diana said, there were several cases of women abusing prescription drugs or alcohol and were completely under the radar in terms of that kind of screening. So the screening has to be, really sensitive to pick up all these various intersections. Pregnancy and postpartum care and support. We don't have a maternity care leave policy in this country. A lot of this had to do with some of them for women who were foreign-born or newly to this country, being very isolated, not knowing any other new moms, not having any connection, and feeling very alone and very apart from support. The fact that we saw this higher likelihood of suicide among Asian women compared to women who give, the number of women who give birth who are Asian, we really saw a variety of cases, again, where women were socially and culturally isolated. Some of them in contexts where, male family members accompanied them to prenatal care appointments and things like that. So we had glimpses, we had flashes of insight into these women's lives, but for me, one of the most, one of the very many things that was very hard about looking through these cases was the lack of information that we had about what had happened to them and what their lives were like. The coroner is charged with being able to determine the cause and manner of death. And so if that cause is fairly clear-cut, she was hanging from a tree in the yard, it was a suicide, they don't really capture all the other pieces that go into why did that person, get to that point. And so we have a lot of information. We have a lot more data on these cases than does anybody else in the country, but there's still so much we don't know. We've created the report, and so we have this data, but we're also going to begin to mine that data more to develop manuscripts on particular topics. So if any of you are interested in that, please talk to me afterwards. So we looked at these preventability QIOs, how could we think about how to prevent this? And we decided to use the public health framework for prevention, which lists three levels. The primary levels, which are targeting the general public, right? And within that, there's that selective prevention, targeting individuals or subgroups who have higher risks. And so in that case, you can read all the kind of themes that we found in the committee. The committee members were the ones who identified what these opportunities were. And so we took all of those opportunities and we analyzed them and we came up with these themes. And part of the action that we'll be taking subsequently to this is to say, okay, for these, in terms of this gap between the OB experience and the mental health experience, let's say for Asian women, let's go to Asian mental health services or special organizations that focus on that population. Let's share our data with them and find out what are they doing to sort of to meet that intersection that women often get caught in or lost in. The secondary prevention levels refers to interventions that could have been taken. So this is clearly what we see when women are put on the wrong medication or they're not provided medication or there was an existing diagnosis but it wasn't taken into account when looking at the current condition. It also includes things like referrals and having a comprehensive system for referring women with known risk factors. If a woman was known to have diabetes before pregnancy, there would be a lot of attention to taking care of that diabetes during that special condition of pregnancy. So, for me, that was one of the real aha moments of our data was that these women had signs, they were telling us, and we weren't looking or listening very well. The other piece of it, And so then tertiary prevention includes those interventions right at the clinical kind of level. Here we found, again, a strong need to educate both obstetric and psychiatric providers. Think about how we can provide resources for psychiatric providers. Like there's I think a helpline in Washington State where OB maternity care providers can call in and get advice on the right kind of medication to give to a woman who's pregnant or postpartum. And to think about how are we going to do that? How are we going to fill that gap? So, overall, we really believe these deaths could have been prevented, and over half of them, were like this close. And we identify these themes that are not new to any of you who are practicing in this area, but we've found when we have reviewed and reported the results of deaths of women due to hemorrhage or hypertensive disorders of pregnancy that suddenly this gets attention. Unfortunately, women have to die sometimes for that to happen. But we're in a way fortunate in California that our rates are fairly low compared to the country, and that compared to women of reproductive age, women who have been pregnant or in that past year are less likely to die by suicide. But we still have a problem, and we are California, and for every woman that dies, another 50 to 100 have a really significant challenge, all right? And there's many more. It's like the tip of the iceberg, the canary in the coal mine kind of effect, right? It's a ripple effect. It affects many more people than just the unfortunate ones who die. So we are really committed and focused on moving forward on preventing these deaths going forward, and all of our information is available online. And can't do this work without the volunteer dedication of these people who gave their time and their energy and their resources. We reviewed what was like 117, 120 deaths in a 18-month time period. We met every 2 or 3 months and reviewed these cases, and we made every attempt to get a very well-rounded and diverse set of experts. And I want to thank the 2020 Mom people, because it was a couple years before we did this review. I had a kind of focus group here, and I asked those who showed up, who were psychologists and mental health practitioners, what information would you want to know if you were going to analyze a case of a woman who died from suicide? And on the basis of their answers, we were able to create a data collection template that really captured many more things than we may otherwise have been able to do. So we're always trying to keep this dialogue going between the people who care for women during this time in their life and the data we unfortunately have to collect when things don't turn out well for them, and with the wonderful volunteer labor of these amazing people. And of course, there are those of us who get paid to do it. And we're very grateful now that HRSA and CDC and other national organizations are really focusing on these issues of maternal well-being. And you may contact us. And I don't know if we have time for questions, but
is there any mechanism in the state of California or at the federal level to be collecting this data moving forward?
Very good question. I could talk for an hour or more on the challenges of data collection. I will say, though, that we in PAMR have, from the very beginning when we did our first phase review, it was in 2008, and we were looking at deaths that occurred in 2002. So we've always been about 4 or 5 years behind due to complex, maybe not so complex, but issues of whose data is it, how soon does it get cleaned, what kind of data gets merged, who does that, how does that happen? It's all that kind of process things. But we have been very busy doing a very high-level speed review of all the deaths in California from 2008 to 2016. And so that is just being finalized, and we reviewed them only to find out what was the cause of death and was it pregnancy-related. Okay. And so we're mostly looking at medical deaths there, but we are finding a lot of mental health conditions among those women who die of medical causes too. So, okay, we've got that. It's almost ready to get born to the public. So we'll be up to 2016 on our maternal mortality data, which is within the first 42 days, and it's largely medical deaths. Then we got funding from the CDC to embark on a local project. We'll be doing an in-depth review of all deaths in Southern California counties, still to be determined, but LA, San Bernardino, Riverside, maybe San Diego, we're still kind of navigating all of that. But the CDC wants California's data. We've been collecting data on our own, and meanwhile, the CDC has been drawing from the lessons we've learned and others have learned, and have created a more standardized way for states to do maternal mortality review committees. And so they gave us a little money to help us make that adjustment to collecting data the way they want and adding it to their national data set. And so we will be starting with 2019 data in Southern California. Fingers crossed. Yeah.
Thank you, Christine and Diana. I just want to thank you, and I'm one of those people emailing you for the last 10 years saying, what do we know? And I want to thank you you're kind of the holder of real data, think of it, and I'm so glad the CDC has recognized that.
Yeah.
Because it's all over the place, and we need to really know. So my question that really, I don't know if how much you can describe this, but you talked about prevention and the way you measured it, strong chance of prevention down to little. And given the fact that we know that once somebody has committed suicide, you look at it, died by suicide, you look at it and realize it's a speeding train. Like there's no guilt and no blame about all of those ways you might have prevented. And I know that you've been thoughtful and really careful about looking at that. But given that, I was curious what went into the groups deciding what makes it a strong chance of prevention, or can you talk a little bit about how you measured that?
Yeah, and if any of the committee members are here and Diana's here, I don't know if Lynn is in the room. Well, like I said, there was a clear sort of maybe dividing line between women who had, every case was so complex, and there were only 99, there were 99 of them over a 10-year period. And so when you try to categorize them in certain ways, a lot of different nuance gets lost. But let's take the cases that involve psychosis, for example, because the incidence of psychosis in this study is higher than the national incidence of psychosis, right? So that meant to the psychiatrists and experts on our committee in this field, which I am not, that means there's a higher risk for women with psychosis to die by suicide, and there is effective treatment, and in this case, if this had been done, this woman would not have died. So there were cases like that were pretty clear, or a woman like going to get, and when I've done analyses on these data for the medical deaths too, and we don't ask the committee to necessarily give us opportunities that are doable. Right? We ask them to really let us know. And so some of them were like, long-standing substance use issues. She needs dual care. She needs substance use treatment and mental health treatment. And I've learned that there's not many places where you can get both at the same time. And given the overlap of those issues that you saw in our data, we can say, well, that's a real need for that. So we can say that is an opportunity, but was her death preventable, in the here and now? Kind of no, because we don't have that. So those kind of cases maybe get us some. Diana, please.
I think the word opportunity is the operative word here, because even if we recognize and even if we treat, we can't always predict that that's going to be enough. But I think as a committee, what we were trying to accomplish, at least in terms of the objectives you set out for us, was all things being equal, if we recognized it, if we treated it, could it have been prevented? And was the opportunity there for it to have been prevented? And I think you're right. It's very nuanced and complex, and you can't just kind of say, well, if this, then that, unfortunately.
Yeah. It was much more complex, and I'll also say that another thing that is being discussed on the national level about this is, does it matter, does the designation pregnancy-related matter, or is it really applicable to this category of maternal death? It is when it's hemorrhage, and okay, she wouldn't have bled, she wouldn't have had a hemorrhage if she hadn't been pregnant, and the opportunities are pretty clear on the clinical place what to do, and we know that that's a OB issue, so, we say it's pregnancy related so that OBs will take care of it. But mental health is a lifelong condition, and women are, like Diana said, at these touch points in care. I don't know. We don't know. We're talking about it. Go ahead.
Last question. Go ahead. Laura Clapper from Cigna. Just to comment on what you were just saying, it's interesting because since it happens after 42 days and the people aren't really continuing to see their OB, I could see people arguing, well, what are the OBs going to do? But I guess I would argue that that's part of like a safe discharge from care. If someone's had a risk, there needs to be a safe kind of discharge back to your PCP plan. So, but that wasn't my question. My question was, as we look at these opportunities, do you have data around like how many people had an ER visit within 2 weeks? I know that kind of was sprinkled in even the last talk, but trying to look at, we know people who are at risk, but where's it, the risk and the opportunity combined.
Right.
That's what I was
Right.
trying to understand.
That would be an excellent thing for us to look at as we dive into the data more deeply, and we do have that data.
And it's interesting, it's kind of a similar situation where we know that veterans are committing suicide at a higher rate, right? And I think it's very similar if we looked at it from what I've seen in the literature about like the more combat you've had, if you've had a mental illness before, if you have substance use, all those different things that may be trying to treat their like kind of a primary diagnosis. And to me, we need to look at ways when someone gets care or goes to the ER in particular, because they're probably at a higher acuity, that they're not sent away to come back. That I almost want us to start thinking about the repeat ER visit is like a never event, right? We can't tolerate having people come in to get care and be sent back without a safe discharge and then come back again. Some of these people are coming multiple times and they're still not getting the care they need. So we need to stand up and say never, just like the wrong-sided surgery. Why is this different?
I have no answer for you. We had
No, I mean, we all
had
need to ask ourselves.
We had an emergency medicine physician on our review, and yeah, these issues get talked about a lot.
Because even like so many of the hospital systems are on Epic, we talked about that earlier, greater than 50%. Why couldn't they be flagged in Epic? So when someone comes into the emergency room, they can see that they have a past history, so they know that there's some protocol that they need to see, like a navigator, a licensed clinical social worker, even if it's going into a room and talking to someone on the phone or through virtual care because they're not in the ER, that they would have some kind of mental health evaluation before they leave, right, for a safe discharge from the ER. There's two things I think are important. One is, why is it different in mental health than medical? I don't think it is, right? And why is being discharged from the ER any different than being discharged from the hospital and having to come back? So I think this idea of readmissions that we think about in terms of inpatient care needs to be brought to the ER, because these people are not being admitted, so they get lost in all the research and data and quality that goes on around readmissions. They're repeat visits to the ER, and so somehow we need to raise the focus and the visibility about that.
Yeah, I mean, it brings up a side but related issue, which is that extracting the information we want from the EMR to do these reviews is going to be harder than when our abstractors went out and looked at paper records and could abstract from that, because they're getting, this high stacks of paper because they want to get all this information, how many ED, whatever. And so it's a self-compounding issue that we have to address.
So
Was there one more question? Oh, you.
No,
good,
I was
good.
just going to say one comment on the Epic. So you, as a payer, can actually request Epic to create that flag. And if there's enough payers who are using Epic, whether you're a hospital or your system, create the demand, Epic will respond.
Well, that's all the time we have for this breakout, so thank you so much for joining us, and welcome everyone back into the main room for the continuation of today's forum.
Thank you.
Panel 3 for this afternoon is Transforming Systems of Care, Hospital Systems and FQHCs Leading the Way. It's my pleasure to introduce Pam Bellick, who will be our moderator for this panel. Pam Bellick is an award-winning health and science writer for the New York Times. Her recent honors include sharing a Pulitzer Prize and winning the Nellie Bly Award for Best Front Page Story. She was selected to be a Ferris Professor of Journalism at Princeton University, is a member of the TED Med Editorial Advisory Board, and was awarded a Fulbright Scholarship and a Knight Journalism Fellowship. Her work has been chosen for the Best American Science Writing. Ms. Bellick has spoken in various venues, including universities and medical schools and the National Academy of Sciences. Ms. Bellick served for a decade as a New York Times National Bureau Chief before becoming a health and science writer. She often investigates complex or controversial subjects, including gene editing, reproductive health, infectious disease, and mental illness. In her spare time, Ms. Bellick is a jazz flutist performing regularly in New York City. I think we're in for a treat. Ms. Bellick.
Thank you all so much. Is this a good volume? Can you hear me okay? All right, I'm not going to be playing the flute for you today. Welcome back from lunch or from your breakout sessions. I spend some part of my time writing about maternal mental health. I've been doing that for several years, and I've written also a bit about how pregnancy affects a mother's brain. And I have already learned so much, even given the things that I've been working on for several years. This conference has been so illuminating already, and it's a joy to have been invited by Joy to moderate this panel and to contribute to this really interesting and fascinating event. So this panel is going to focus a little bit on approaches to solutions to some of the problems that we've been hearing about all morning. And I'm going to introduce our four panelists who all have, in some way, are involved in creating and shaping programs that are trying to address the really unmet need of maternal mental illness, and how to fill a lot of the gaps and the breakdowns in the system that you've been hearing about so far today. So I'm going to introduce them, and then we'll have a conversation, and then we'll take some questions. Please feel free to submit as many questions, I guess we'll be doing it that way, as you like. So first, I'm going to introduce Barbara Sheehy. Barbara has spent the majority of her career managing public health and nonprofit programs serving children with special health care needs and their families. In 2013, she began leading collaborative health system improvement projects. And then a few years later, she joined Dignity Health as the maternal mental health project manager. And Dignity Health recently merged with the Catholic Health Initiative, and it's now called Common Spirit Health. Barbara received her degree in psychology from the University of Colorado Boulder and her master's in speech pathology from the University of Wisconsin-Madison. Welcome, Barbara. Next, I'm going to introduce Melissa Hanna, who is both has a law degree and a business degree, and she is co-founder and CEO of Mommy. And we're going to hear a lot about that. She's going to tell us about its comprehensive prenatal and postpartum care management platform. It has a staff of trained and certified maternity support professionals, and they are here to deliver education and guidance to new moms and new families. Melissa got her business degree at Claremont Graduate University and her law degree at Southwestern Law School. She has worked in operations and strategy at startups in healthcare, education, digital media, and consumer goods. And she also worked at Columbia Business School. And her MO basically has always been to forge cross-industry collaborations and partnerships to solve big challenges, and she believes very strongly in equitable access to health care for women and children, and that's, I think, what all of us here are hoping to talk about. Sitting next to her is Mona Patel, who is an attending physician in the Department of General Pediatrics at Children's Hospital Los Angeles, and also an assistant professor in the Department of Pediatrics at the Keck School of Medicine at USC. And Dr. Patel is a fellow of the American Academy of Pediatrics and board certified in pediatrics. And in addition, she was named a top doctor by Pasadena Magazine. Now, we heard an incredibly moving story this morning from Stephen DeKilly. I think, you know, all of us were very affected by the story of what happened to your wife. On this panel, Stephen is here to talk about what grew out of that, which is a foundation that he created in the wake of his wife Alexis's passing to increase awareness concerning women's perinatal mental health issues and to improve treatment outcomes for women and their families in the Pittsburgh area, which is where you're from. The foundation, in a partnership with Highmark Health and Allegheny Health Network, recently opened the Alexis Joy DeKilly Center for Perinatal Mental Health in Pittsburgh. This is a 2.5,7,300 square foot state-of-the-art facility offering women and their families access to a broad spectrum of treatment options. And Stephen is also active with many other women's mental health organizations and sits on the board of Postpartum Support International, and also with his family owns and operates the Pizza Roma and Pomodoro Italian restaurants in Pittsburgh. All right. Do they deliver to LA? Okay. All right. I would like to start with Melissa, sitting here directly to my right. Melissa, could you tell us, grab a mic. Tell us a bit about Mommy. I'm interested in hearing what problem you were seeking to address when you established Mommy and how it works, and just sort of a little bit about your startup journey there.
Hi. Okay. This absolutely has been a journey and one that's been mostly uphill, to build a comprehensive prenatal and postpartum care platform that is really crossing over between the tech industry and Silicon Valley, sort of in quotes, and the healthcare industry, where we really want this to be focused, but where it also has to fit into the technology components of healthcare. We initially tried to solve for what is clearly one big part of the broken system of maternal infant healthcare, which is the lack of unified IT infrastructure for being able to rapidly and effectively communicate with multiple providers who are supporting the same patient. We know that in maternal infant healthcare, we've got it's not just the OB and the pediatrician. There are a lot of other support professionals, ancillary care providers, and community-based organizations that can and are often a part of the patient's care experience. How do you effectively communicate what's going on with the mother-baby dyad at any moment in time when you've got professionals that are all using different tools in different buildings, and sometimes in different cities or counties, and in some cases still using paper charts to document their observations, especially in the home health setting? So we thought that this might initially be a software challenge. We went ahead and we started building the software that would allow for all of those providers to connect up, and for those folks that are still using paper charts to, in time, move online and go digital with their own charting and documentation and communication between patients and also with their fellow providers. We started taking that to systems, which is what this panel is about, and taking it to FQHCs, taking it to multi-facility hospital and health systems, and saying, hey, look, we made software. You should be able to now talk to anyone else who's taking care of your patient once they leave this building. And behind closed doors, C-suite executives kept telling me, okay, but who's going to actually do the work? We don't have enough people here to support every mother coming out of this building. We don't want people to know that. We've got programs, but we don't necessarily have the operational capacity to make sure everyone can participate in these programs. And that began the second part of this journey, which was to not just build a software company, but to build a software plus services company that would staff up, as Pam said, with the professionals that would allow these organizations to extend their capacity and to provide more comprehensive support and care coordination to every person who needs that, not just the folks that we think need it in that moment or look like they need it, or, oh, something on your chart tells me you might need it, but actually understanding that risk, whether it's related to clinical, obstetric risk, pediatric risk, mental health risk, all of these things are constantly varying over time. So we've got to be there to catch people before they fall. So that's what Mommy does. And we partner with organizations, including Ultimate on the panel today, to do that work.
Well, I'd like to hear from Dr. Patel about how your experience using Mommy. How did you end up deciding to use it, and how has it worked for you? What are you actually doing with it?
So just to give a little bit of background, kind of our healthcare system. So I'm a practicing pediatrician. I'm vice president of ambulatory operations for Children's Hospital Los Angeles, and we're aligned with Ultimate, which is a federally qualified health center. And what that means is that we serve a predominantly underserved population. So 92% of our catchment sort of group of children that we care for are in underserved regions of Los Angeles, Orange County, and beyond. Years ago, when I first met with Linda, Melissa, everybody, I think as a pediatrician, we know that in order to optimize the health and well-being of a child, an infant, a neonate, I need to make sure that mother, family, unit, dyad, social supports, everything is intact, right? And I think it's that upstream view that we've always taken. Realistically, my OB colleagues, when you give birth, OB is not seeing women usually until 6 weeks postpartum. I'm the one that's actually seeing the mothers. And it's sort of that advocacy and that push to say, well, I should be paying attention, I should be screening for depression, I should be looking at what are the supports, because ultimately I need to make sure the care and well-being of that child is made whole. And I know nutrition and growth and everything is going to be wholly impacted by mothers' mental health and support systems. So we started screening. We started doing all types of screening. We see babies usually 24 hours to 2 days after birth. We've built a program within our FQHC medical home with lactation, with social work, with kind of wraparound services based on our screenings, and really training our pediatricians, our residents, and our future sort of physicians in taking the time to ask the questions, looking at parents in the eye. One thing that I'll say when I teach my residents, you know, that first visit, I know that child's life is going to be my job as a pediatrician, but when I walk into the room, I make sure that the mother is comfortable. Is she the one sitting down? I'm going to take care of that baby in a minute, but I need to make sure, and I ask those questions. How are you doing? How are you feeling? Are you engorged? Are you having pain? And I focus, who's supporting you at home? And I found when I started doing that, and I'll admit I started doing that after I had my own children, and I realized what it's like. Deep respect. About 50 to 60% of the women just started crying, just because I asked that question. And I got so many overwhelming emotions, and that's when I started realizing how important it is in my job as a physician and a pediatrician to ask those questions. And then along comes the team with Mommy and saying, beyond that, how do we support and integrate the extension of mental health services and screening? And in our program actually budded from home phototherapy, understanding that when women are discharged from the hospital, the last place you want to go with your baby who has elevated bilirubin is back in the hospital. We want to be in the home environment. And then working with our team, now that we're dispatching home care and lactation services in the home environment and doing screening, we started realizing with our population, we have families living in cars. We have families living in garages. We were able to, I think I shudder when Linda calls me directly, and that's a phone call I answer right away, because it's sort of like, I get palpitations like something's wrong. She's calling me personally right now. We had an incident that you called me about, we were worried about domestic violence. And these are things that we are able to step in with our team of social workers, and that constant following up, constant contact, and working with sort of that extension care. I think those have been the biggest lessons learned.
Thank you. Barbara, so you have a digital approach as well, right? You guys have developed an app. Can you talk about that, and also anything around that you feel is relevant about your approach to maternal mental illness? I think you were pretty early in getting something established to directly confront this issue, right?
Yes. So in 2016, our Dignity Health leadership, including our philanthropic leadership, selected maternal mental health as a priority patient care initiative. And at that time, we had 29 birthing hospitals across California, Nevada, and Arizona, with about 60,000 births a year. Since then, with this recent merge in 2019, we have maternity hospitals across 13 states, so 65 hospitals, and we're actually going to be have the privilege of having 1 in 40 babies born in the United States born in our hospitals. So part of what clearly drove the interest is the sheer number of women and families we have an opportunity to impact. And yes, one of the things our leadership was interested in at the start was any kind of opportunity for using digital solutions to support as we started looking at providing patient education, screening, and so forth. Also in 2016, we were launching a pregnancy journey app called My Baby. It's available to anyone. And one of the things we did initially was we made sure that we were inserting emotional wellness, mental health content into that app. And then gradually we were able to add the Edinburgh Postnatal Depression Scale for a woman to self-administer. I'm really appreciating this conference and then this panel, hearing about the ways to go beyond to really get more of that interconnectivity.
Okay, great, and we're going to talk a little bit more about that too. Stephen, so you have sort of this bricks and mortar approach, which I think is pretty new, right? Is it like a year or two old?
We had a temporary facility for 3 years in the hospital that started with one space, and then it grew so quickly we had 3 different spots in the hospital. Women would start here, then move to the second floor, the third floor, because our project kept getting delayed, because as my perspective would change and I would learn more and the doctors would learn more, we kept expanding the program. So it took about 2.5 years, and but we opened in December 2018.
So tell us how it works. I think there aren't that many freestanding, kind of maternal mental health units in hospitals or centers. So what does a woman have access to? What types of patients are you seeing? How do they get referred?
Sure. So my wife's problem was, if you look at all her screenings, it's horrific what she was writing down and how she was answering questions. And when a mother screens positive, where does she go for help? And that lack of access kind of became my passion, and decided to build the center that I believe would have saved my life, or saved my wife's life, if she had access to it. And we take a family-based approach where we invite not just mom, but her baby, her partner, and also any other children she might have at home, and include all of them in the program. And we offer, meditation, yoga, mindfulness. We have a chef's demo kitchen where we teach women how to eat healthy foods and prepare them, and encourage their husband to participate. So if nothing else, he can cook dinner and take something off her plate when she gets home. And they also leave with a box full of all the ingredients so they can take that home and prepare those meals. We have lactation consultants there. We have quiet areas where mom can just kind of nod off and get some sleep if she needs it. We have individual therapy as well as group therapy. We have. It's really amazing how comprehensive the program is, and we truly try to encourage the whole family to participate, because I feel, as a man, and I'm usually the only man or one of few in the room, I think there is we always talk about motherhood, but fathers get left out, and I don't think it's because they want to be. I just think that's, for generations, that's how it's been. And I always say, men become dads the day their baby comes home from the hospital. Women become mothers the day they get pregnant.
So it's inpatient for the mom? And
It's not inpatient.
Not inpatient, okay.
It's a 3-hour, twice a day, intensive outpatient program. And we treated 3,000 women last year in Pittsburgh. And we also, if you screen positive, we're trying to get under 24 hours to see a perinatal mental health specialist, but we're under 48 hours, which is, I'm proud of that.
That's great. I'd like to ask you all, maybe we can even just go down the line, Stephen, if you want to start, just, anything else you can say about the results that you've seen? It's a little early for your program, but I mean, in addition to 3,000 women is a lot. Are you measuring this in any way? Is there a way that you've been able to do follow-up on these
So for
patients?
me, I'm not a doctor, I'm an advocate and a fundraiser, and so I raise money to make sure that moms and families get the best experience possible. But I think with our program, one of the unique things is baby can participate. And we took a very direct approach, saying, what are the barriers to care? What prevented you and your wife, myself and my wife, from getting the care we needed? And then also, as we learned, and the big thing was, it's hard for moms to get to the hospital. So we offer free transportation to and from the facility, as well as childcare for all of the children that mom might have at home. And so I think the healthcare experts would say that the number one demographic for people that miss doctor's appointments is mothers, because they're busy. But guess what happens if mom can bring her children? They don't miss their appointments. And so, we offer free transportation to and from, as well as childcare, and that's been amazing.
Great. Barbara, do you want to talk about the results that you've seen? And each of you, too, if there's an example that you'd like to share, that sort of, a story of a particular patient that would kind of illustrate this, I think that might be powerful too.
So one of the main things that we did in 2017 is, after surveying our hospitals, we first piloted and then began screening universally all women who give birth at our hospitals prior to discharge. So each woman gets some education, she's screened, and based on her score is referred to social services as needed for further assessment and follow-up. And so we've screened over 127,000 women since mid-2017. And one of the things I'll say, that with our implementation, it's our staff, our hospital staff, who have taken this on, and they really embraced this work. A lot of the nursing and social work staff were actually, in spite of the fact that it was additional work, they were really pleased to do it. We also began providing in-person training across California, Arizona, and Nevada for our staff and providers, but also for the community. So free trainings. We partnered with Maternal Mental Health Now and had excellent feedback on those trainings that lasted from 2 hours for our providers to 2 days for other clinicians and such. So we trained over 1,100 clinicians and community partners. Then the other things that we are doing in addition to really trying to enhance education of our patients, our staff, and the community, as well as screening, is we're piloting various ways of providing intervention. And our hope really is to catalyze change, so to pilot something, sometimes in partnership with others in the community. So in California, we're now providing a perinatal psychiatry consultation service so that any provider in California can call a perinatal psychiatrist Monday through Friday in the afternoon and in real time get a curbside consultation. So this is one example of ways that we're trying to support our providers to really build their capacity to better identify, diagnose, and then treat women, sometimes until they can get additional care. As we've all talked about, the challenges of getting appropriate and timely care, whether it's for psychotherapy or for psychiatric care, is very challenging. And then other things we're doing, we're offering, again, free to community and staff, intensive facilitation training to try and catalyze, support more groups for pregnant women, postpartum women, but also some specific groups. So it might be groups for dads or parents who have kids in the NICU. We know that there's a lot of sort of subpopulations that all fit into this desire to better support perinatal women, infants, and families.
That sounds really, really important. Mona, you were giving some kind of compelling descriptions of where you find your patients and where they end up. Can you think of a story or two about a specific woman who was helped through this outreach that might have otherwise fallen through the cracks?
Oh, sorry, so many. One specific one that comes to mind is baby that was born at 40 weeks and was actually in the NICU for feeding and growing, discharged, and was seen by one of our pediatricians a couple days post-discharge. And we did our screenings, everything was reported okay. Baby was dropping a little bit of weight, which is normal right after birth. And mother seemed very supportive, family was engaged, father was at the visit. I think maternal grandmother was there, flew in to help the family for the first couple weeks, and then did a follow-up visit a week later to check baby's weight and see how child is doing, and noticed that the baby dropped a little bit of weight, started asking about kind of lactation and breastfeeding. Mom reported that she was engorged, having a lot of nipple tenderness, so had mastitis, which means she had fever, starting to struggle. Grandma actually had to leave early, and then father was working nights and taking care of disabled parents who moved back into the household. The way that we saw it as pediatricians in our clinics is baby kept dropping weight. We would say, okay, then come back in 2 days. Still screen and kept scoring okay on the screens, right? We did the PH2, we did the Edinburgh, but we weren't catching it. So based on the weight, kept probing and asking more questions, and that's how we got all these stories of the actual lack of support system that started to evolve. We were able to get social work to jump in. Also found mom was in a place where she's the only one who had children and lost contact with her friends and was in this environment of isolation at home. And having close contact with our social workers, we're able to kind of wrap in a little bit of CBT and whatnot and start building up a social support system, getting mom to kind of start doing meditation and yoga. Working with father, had him come into the visits, and then we naturally, and doing a lot of support for lactation, started seeing baby's weight start to rise. So it's so complicated because we can do a lot of screenings. We can kind of say, okay, fine, this child or family is doing okay and we don't need it, but I think it needs that extra level of constant asking the questions And it's that constant follow-up, and that's how we started seeing it manifesting. Since then, we have grown to not just screening, but thoughtfully asking the questions over and over, closely following and seeing what's going on with the dyad and the whole family unit. And collaborating with a lot of neighborhood partnerships and bringing in mental health services, because our need is extraordinary. And there's a profound lack of mental health resources. So we're looking at virtual options. We're looking at home mental health visits. We're looking at working with mommy. We have to be so nimble in so many different avenues to touch our families, because the other reality we face is reimbursement and cost and what it takes. So you have to have multiple different programs to be able to touch the population.
And that kind of perfectly brings us to the need that you're filling. I think when we were touching base on the phone before this event, you had a very compelling story about what your platform was able to recognize. Can you talk about that?
Yeah, actually, I was thinking about that story, and I was also reminded of another related to weight. So I'll share just two little vignettes about what care coordination in the digital age can look like through a platform like Mommy or others that are doing this kind of work, either clinically in maternity and in pediatrics, or specifically within mental health and emotional wellness. The first story that Pam, that you're referencing. We can deploy Edinburgh screenings through the platform. Those can be programmed to go automatically out to patients at certain periods, at certain points in time, or it can be manually deployed by a provider saying, "I'd like to have this patient self-screen." In this case, a pediatrician had onboarded a new patient to the practice with a 14-day-old. And at that marker, she received a 14-day postpartum check-in, including an Edinburgh screening. She scored 21 out of 30, so in a very high-risk zone. That immediately flags in the Mommy platform. Our care managers, it's like red lights and bells go off right away for someone to be immediately in touch with the patient. The clinical protocol that we follow is to verify the reported results. So that includes a phone call to that patient immediately. On her end of that screening also, she received her score, some education, and sort of a message of like, hang tight, we're gonna be in touch. And so got a call on her cell phone, spoke on the phone, and ended up crying on the phone with the care manager and saying, I just don't feel like myself, and everyone else is saying I'm doing really well. She was not otherwise scheduled to see her OB/GYN for another 4 weeks. So we've got now a case, and this was actually through our partnership with UCLA Health System. So we've got a great health system here with a lot of resources internally and psychiatric and psychological supports in place. But this patient is otherwise falling through the cracks because she looks great on paper. So in that, it was a 10 minutes phone conversation. It really is, our protocol is to verify the symptoms and then immediately flag and escalate that patient back to primary care. Now, mind you, she was onboarded by her pediatrician. Her OB/GYN was not a member of Mommy, hadn't actually activated a practitioner account through Mommy, but we know who her OB/GYN is because she's part of this health system partnership. And so our response then is to call the OB/GYN. This was after hours, so we're talking to someone on the after hours physician line, relaying what's going on, coordinating care, basically figuring out what the next course of care is. And mom is saying things like, I had this crazy thought, like maybe I should leave the baby with my husband and walk into oncoming traffic. And I'm saying, I know that that's not right. And my friends told me I was going to feel a little weird after I had the baby, but is this what they were talking about? So you hear all these bits and pieces of stories we've all heard. And so to bring that together now, we've got physician on the other end, facilitating care and dictating, okay, we're going to get this patient in 9 a.m. the next morning unless patient needs inpatient service tonight, unless we're going to facilitate a readmission, in which case that's not what happened here. This patient was able to be supported at home, receive overnight support through the platform, and then was on the calendar 9 a.m. the next morning to see her OB, who then communicated back through Mommy and said, I had no idea, thank you so much for bringing this to my attention, which is usually what ends up happening when a case like this occurs, is that physicians want to know but don't otherwise know. Just a quick thing on baby weight and just the flip side of it. We had a pediatrician contact and actually add a mom. So the majority of our patients are onboarded by a primary care provider, someone who's saying to them, I go home at 5 p.m., but these people are open all night. Really nice pitch, right, from the doctor to the patient. So you've got a pediatrician here, contacts us, onboards a patient, and says, I needed to keep an eye on the baby. This baby's been gaining a lot of weight lately. Baby was in the 50th percentile, looking real good. Next week was in the 60th. Okay, now they're in the 75th, and actually baby just came in yesterday at 90th percentile. I keep checking with mom, and she's like, everything's great. I'm breastfeeding like a champ. Now, the pediatrician knew just enough to say that something's not quite right, but not necessarily to figure out where to go from there. As it turned out, through conversations and inviting this mom into a digital support group with other mothers with babies of the same age, she revealed that she was experiencing severe anxiety living in her apartment building, where another mother in the last year had been yelled at by neighbors for having a crying, screaming baby. So what do you do when you're crying, baby's crying and screaming? You feed your baby. Now we've got a baby in the 90th percentile. So, right, the flip side of this, but these are the stories that when you kind of pull back the curtain, you figure out that there actually is often another dynamic going on that may be affected by mental health.
Oh, those are both really amazing stories. One of the things, I mean, I don't have to tell any of you in the audience, but one of the things that always, kind of fascinates me about this area and what makes it so challenging is that it is so individualized, and as I think Mona, you were suggesting, you can develop something at any point in the perinatal period, and if you're not caught at the 6-week OB visit or the 2-month pediatrician visit, that doesn't mean that you're going to end up not having an issue at 4 months. So you're dealing with a very rapid, very fluid and unpredictable situation with a lot of different inputs at different times, in the mother's experience. I think there are going to be a lot of people in the audience who are going to want to learn about how they might try to emulate some of the programs that you have, and so I always like to ask people for a challenge that has come up that made you have to change something. We've talked about the features. Tell me about a bug that came up and that you had to swoop in and say, no, we can't be doing it that way. We've got to be doing it this way.
I think for us, it was what makes our program special is that it's a very patient-forward approach. And even though I don't work in healthcare, we kind of we did a vision board like early on, and it was what were the obstacles we faced and what would the dream scenario be like. And I was very adamant, and the health system was very understanding that of certain things that were important to me, like I'm a restaurant guy, I like to cook, and I wanted I wanted a demo kitchen in it. And so it was practical, everyday solutions to problems. And I found that oftentimes things get really confusing, and usually when it's confusing, it's because there's just a bunch of BS mixed in. There's really practical, simple solutions to problems, like solutions or like transportation and childcare, if you get creative. So I'm not a doctor. So I just try to figure out what problems I have or other people that I know hearing stories like this and try to think of simple solutions for those problems.
A couple of examples. I think when it comes to trying to introduce new interventions or support ongoing ones. I think an example with the Perinatal Psychiatry Consultation service. So we modeled that service after the McPat for Moms program out of Massachusetts, the consultation component so far, and it took a good 18 months to, keep after getting everything in place to actually be able to offer that service. So it took a lot of time and persistence to get it through legal and so forth. And then once we launched, what we are finding, and this is what we hear from others across the country that are doing similar programs, it takes a lot of effort to engage providers in using the service. So the idea that you build something and they will come is not in fact, necessarily the case. In a similar way, we launched in the north part of California a maternal mental health telehealth service where women can access psychotherapy online. We have a nice setup, so basically their insurance could be billed, and if not, it would be covered. We had an outside grant for this. And the same thing, while it only started in September, we're having to work very hard to engage the community and providers in making use of the service. So the whole outreach and marketing and having people come to trust a service, I think, is really important.
So how are you doing that? I mean, are you going out, practice by practice?
Yeah.
Are you making lots of phone calls? Are you, billboards? I don't know.
Yeah. So using the consultation service as an example, this is also where, learning from small Massachusetts how to do something in great big California, it's going to be a little different. In that case, we are offering to have our perinatal psychiatrist actually go do grand rounds, remotely join a staff meeting of OBs or pediatricians, just to share a little bit about how the service works and so forth, and then promoting it through organizations like ACOG and Academy of Pediatrics and so forth.
Mona, do you have a problem that came up or a challenge that you...
I feel like I live in the world of challenge. Just because you have to take a patient-centered approach, right? It's easy, I think, as physicians and health systems to prescribe and think that we know best and we're gonna decide and we're gonna implement. But gosh, you just get kicked down every single time. We had physicians that said, I'm gonna start prenatal classes and I'm gonna educate and I'm gonna teach the residents and I'm gonna do this and I'm gonna make it Monday afternoon. And then you go months and nobody shows up. And then you realize, well, how come nobody show up? I have a doctor sitting here and then, okay, what if we engage with WIC? What if we do this service in the community? What if we do it in the evenings? What if we offer childcare? And you start seeing all these iterations and finally the population starts to engage, right? So you have to be patient-centered, and we've gotten our butt kicked constantly and continue to do so. I think understanding the different challenges with different patient populations. So in my new role as VP, my commercial lives have very different challenges in access to behavioral mental health services, quite frankly, from a payer perspective. My underserved populations have rampant changes in legislation constantly with coverage and reimbursement modeling. So it's being nimble and seeing, but I think the most important thing with this topic and integrating social emotional determinants of health and upstream is to always work towards that North Star and that vision, and you continue to persevere and say that it has to be built with an equity lens. It has to be prioritizing the health and well-being of our populations, and you kind of have to be scrappy and change your system based on your patients.
Melissa, do you have an example like that too, or something?
Yeah, I would say a lesson absolutely from this. So this is where being a technology company and having an in-house development team has informed a lot of the way that we actually do this work of transforming systems of care. So in our development practice, we approach things from a very agile methodology or standpoint. It's something we're constantly iterating on what we're building and testing and looking at data. So it's a very data-centric approach to say, okay, what's working? And data doesn't have to be a very highbrow concept here. The fact that no one showed up for prenatal classes on day one, that's data. You had zero, and so really going from that point and saying, okay, well, we know that our hearts are in the right place. We know we are trying to do the right thing, but here's the result we're getting. How do we how do we really build on that from that number 0 and getting it to 1 and above? What I would say is sort of the bug in doing this work that we are constantly fighting against is, and this is sort of a weird intersection we're at right now. It's not going to be this way forever in this industry. But I go into a lot of spaces where health system leadership say, yes, we want this. We want help. We are so committed to doing this work. But do you guys integrate? So I hear this I word, integration. Now, maybe you've heard some of this in some of your work, right? That's not the I word that matters. It is not about integration. I can tell you why in a second, but I'll tell you what it's really about. It's about implementation. It's about how do you get this work out into the community, out into the patient's hands, out into the provider's hands, and that is where all the bugs really are. Integration is actually pretty easy, and I'll tell you the secret, most tech companies can do it. If you want to work with them, if you want to bring that tech solution into your organization, that's not going to be where the challenge is, because if they've got developers, they can figure out how to connect up to whatever you guys are using. The hard part is making it possible for everyone else to use the thing that you've built. And so for us, literally, we have to go around the community when we do a rollout or an implementation. We have folks that are called community partnership coordinators. They go to your practice. They go to your home. They go to your community center. They go to your WIC center. They figure out how to make it possible for you to onboard into mommy, to use mommy, to make mommy work for you, whether you're a patient or a provider. It always is going to come down to that, that challenge of how do you roll this out in this particular city, this region, this county, this state. The funny thing about integration, actually, Ultimed is a great example here because, well, no, we had the benefit of working with Ultimed early on in their own transformation process, as many parts of the organization were going toward digital solutions, and Dr. Patel was leading all of this. So imagine sitting down and saying, we've got software. We want to connect our software up to your software. We can integrate. And then hearing,
we're changing the entire EHR.
Not yet. They changed the entire EHR in the middle of us already working with Ultimed. What we found was that integration can sometimes mean we've got a PDF here, it's secure, it's encrypted, we're going to send it to you, and then you can de-encrypt it and bring it into your system on your end. Or we're going to fax it, if that's what it takes. Because some tech companies, like ours, still fax. Because our customers still fax. So that's really what it comes down to. I think that it's very important that we start to pull back that curtain on what this work really looks like on the ground.
All right, should we take some questions? Are there some out there?
My name's John, I'm a pediatrician, and I help innovators across the country at all levels of healthcare, government payers, policymakers, health systems, tech companies, integrate and implement in a financially sustainable way and scale what they do. So the first thing I want to say, Stephen, first of all, thank you for sharing your story. It brought up painful memories, actually. About a year ago, I met a father who had had a loss when we, at the Center for Youth Wellness at the time I was there, wanted to study childhood trauma and how it leads to violence, particularly intimate partner violence. And he started a foundation called the Aviel Foundation. You may have heard of this story. And after I met this gentleman, who everybody described as the ultimate collaborator, integrator, brought everybody together, he had lost his daughter, I believe, in Sandy Hook. And that's why he created the foundation. And a few months after we submitted a grant to do this research for his foundation, he took his own life. And so I think just a comment on this, it's very, very important that as we do this difficult work, we are all thinking about how we're supporting each other and ourselves and not just the mothers. You look like you're doing great with self-care, so not specifically, but I think it's a very, very powerful anecdote and really touched my life. And he was an incredible man, but you know, we can sublime what happens to us in life, but things do linger, and for all of us, really, I'm speaking about myself, it's very important to take care of ourselves and each other. And by way of that, so I love to help people scale what works, no matter how complicated. Those who know me, I don't shy away from anything complex, so you need any help with that, how to grow it, I'll be there for you, okay? Thank you for what you've done. My question to all of you is, so as part of all the work that I do, I get to advise some folks who may have some influence. We've heard a lot about the payment at the Federal Centers for Medicare and Medicaid Services. around maternal infant healthcare quality and innovation. I'm blessed to advise them in the state of California. So if you had one thing, just one thing that policy or payment could change to just flip the switch and would make a huge difference for those that you serve or your innovative models, open to any of you, what would it be? And I literally will relay this, so have at it.
First and foremost, I think equitable reimbursement for the actual work it takes to take care of the population. And what I mean by that is not, right, that's just like big scale, I'll go right there. Not just fee for service, not just the physician fee, but the social work, the nutrition, the mental health wraparound, everything, so that the collective reimbursement actually reimburses what it takes to take care of an individual, family, and support system.
I take a different approach to things, but I think the one thing that's made our program so successful is storytelling, because we've been able to give a voice to people that otherwise would not have one. We did a campaign, it's a green couch. I don't know if some of you have seen the commercials, but women's health was the big initiative within the health network. And the first year they wanted to highlight our program, but they weren't sure how to do it. And so there's a commercial of me pushing my daughter, and it was 30 commercials in 30 days, 15-second spots, of all the things the health network was most proud of. And that went from doctors to nurses to patient stories to different advocates. And of all these amazing things going on in the health network, when you talked about maternal mental health with our commercial was more successful both on TV and social media and every way you can gauge it than all the other 29 put together. So it showed people care. And helping moms is helping families. And the second year, I said, how are you going to highlight our program again? And the couch was for women only. And it was always one woman talking with another woman. It was a woman that was going, maybe, say, cancer. It was a woman that survived talking to someone that was currently in treatment. And they would just capture these amazing conversations and highlight certain parts of it in the commercial. And I said, they kept filming two women, one that was better and one that was still going through, but the message wasn't right. And I said, well, you need to put a husband on with a man on with one of these women. And they called 2 months later and said, we want you to be the guy. And so I'm sitting on the couch, on this women's iconic green couch, and we're midway through and everyone in Pittsburgh knows not everyone, but a lot of people know the story. And the woman says, oh my God, you're Alexis's husband. And it was 4 hours of shooting, but there was this amazingly powerful commercial that came out of it. And they did like a 2-minute piece, 1:45, and it was so well received. Again, of all the 30 different initiatives, maternal mental health was #1. This past year, we were trying to find a bigger voice, so we were able to get Chrissy Teigen to come and say, there needs to be centers like this in every city in America. And so we launched the My Wish for Moms campaign, and we had 16 million people participate worldwide from 116 countries. I think there's like 186 countries in the world. And it was really unbelievable. And so I really think something that's really overlooked is the power of storytelling. And that has really driven this program from day one.
Good afternoon. Can you please speak more about the community partnerships and community engagement connected to language access? I'm curious from the beginning in terms of outreach and then also to utilization, how the systems capture perhaps, let's say, a need for Tagalog-speaking communities to then access services. So not just translated materials, but also what is in place, trying to connect it to if there's an underutilization of services, how to connect that need and how everyone can help. I don't know if that is clear.
I'll just say, in the hospital setting, what we do is, in fact, make sure that our screening tool is available in any language that is spoken. If we get a call from a hospital, at this point, I think we have the Edinburgh Postnatal Depression Scale and our patient education information in 13 languages, in terms of assuring that there's appropriate, linguistically and culturally appropriate care in the community. We're certainly not there.
In designing, actually, it comes back to implementation, but in designing a rollout of a program in a community, culturally competent care is an important pillar of designing the implementation process. And what I mean by that is that as you are, whether it's physically or sort of digitally rolling out a program across a region, part of that work includes understanding who's in that community and what sort of resources, digital or physical, like whether there are literally centers that people go to, whether those are nail salons or hair salons or supermarkets. There are different spaces within any given community that become hubs for information, for support, for social and emotional support that have to be incorporated into that strategy. So going beyond just translated materials really includes understanding who and what are the pillars of that particular community that are going to be the touch points for successful implementation. And that's one way to think about cultural competence, is that you're not always the one who's interfacing with that patient. So you have to figure out who else is and how you can support that person.
What are the barriers to integrating the two-generation approach in pediatric hospitals, and what's the first step to dismantle the barriers? I think this was meant for Dr. Patel.
Barriers, I hate to keep coming back to reimbursement and those issues, but it's a reality. I can say that within the Medicaid system, we can do it. We have been doing it for many, many years, caring for the mother-infant dyad. It's actually Dr. Goldfinger who started working with us many, many years ago in helping establish kind of those rules and constructs and all of that. I will say, again, going along with that kind of vision and equity, we provide the services, regardless of payer. Okay? While we're on the back end advocating, we're working with legislation, we are working with the health plan, we're going through contracting, and we have teams looking at that. The care I will, and I'm most proud of, is equitable, in that if we can't get reimbursed, we're still going to do it. Don't tell the C-suite that, because that's important, right? And it's now, okay, we're still going to provide the service, but now how can we go to the plans? How can we go to the payers? And how are we going to justify all of this? And how can we look at innovation and extend care? But it is a challenge. It is a challenge. And I think it's thinking out of the box also in convincing my colleagues and everybody else that it's important to provide the care for the mothers, the fathers, and everybody else in pediatrics, because it's not just about the child, because of the overwhelming impact that family has.
Hi, my name is Amy. I'm a pediatric occupational therapist in a NICU, and thank you for all your information. I'm just curious, in all your work in the larger systems, if you have any thoughts on how practitioners could do some creative collaboration. I feel like a lot of us are kind of out there all with the same good mission and kind of reinventing the wheel. And, you know, we've talked about piloting different things like bringing social workers into the NICU or bringing occupational therapists into the pediatrician's office. Or I'm just curious if you've found anything that has worked.
I would say for our work originally with Dignity Health and now Common Spirit Health, this is part of our process. Our planning committee looks at opportunities to pilot, improve access to care for women. And I think there's a lot more that can be done. I'm thinking to the earlier question about, one thing that we'd like to do different. I think having more, for example, social work support in a hospital and also in outpatient settings, very often, as has been brought up before, there are fantastic services and resources in a community, but it can be very hard to know about those, keep up with what's current. That's definitely true in a hospital setting where people are so pressed for time. So I do think an investment in a person whose role it is to really be hearing and interacting directly with the patient, and then really knowing what's available, having relationships with people in the community to tap into all the different types of sort of modalities for care and support. So I think having that role, a navigator sort of role, it would be a big help to make better use of services.
I think the eternal optimist and dreamer side of me gets excited because I think in healthcare we work in a lot of silos, but there's a lot of people engaged in the mission doing that work in silos, right? And it's about how do we break down those barriers and have that conversation about how to collaborate. So I'm going to give a shout out to Apple, okay? She came to my office. Gosh, what, a year ago? And started planning and saying, I am seeing these babies, and we're doing dysphagia, and we're doing X, Y, and Z, and how can we work with lactation? How can we work within the primary care environment and collaborate and do this work together? Because we're doing it here on this side, we're doing it here in pulmonary, we're doing it in NICU, we're doing it, and it makes sense because we're doing the same work together, right? Same conversations with social work, with nutrition, with physical therapy, with our nurses, and everybody at our hospital. We've started a formal new committee. Well, there's collaboration and advocacy on stronger, bigger platforms, but we've now started a social emotional determinants of health committee, which has 6 different sectors: behavioral mental health services, 1, food, school systems, homelessness, kind of the whole gamut. And I'm so proud that it's one of the things I co-chair at our enterprise, but I have representation from everywhere. And it's so exciting because you have that like-mindedness in all different professions, and you realize, gosh, you can take care of this, we can do this, and you're stronger together to do it. And then the resources come out of the woodworks, and then you start seeing how can you innovate and how can you get the work done for the population holistically. So I think it's about breaking down those silos and agreeing that we can actually do the work together, because a lot of us want to do the work.
Hi, I'm very much enjoying this presentation. I'm actually a new mom myself, so I just had a baby mid last year, so a lot of this hits home really hard for me. And I work for a tech company down in San Diego, and what I wanted to know is what you think employers can do to better support mothers. I mean, as a company, we provide pretty rich health insurance and leave benefits, but I know that's not available to everyone at large. So if there's things that you think that can be done that may not necessarily be tied to that, is it better contact with the family while they're out, say on maternity leave? What is it that we can do to help support moms a little bit better?
That is a great question, and I think it's a complicated answer because we talk about finding ways for employers to support new and expecting families in and outside of the workplace, and even just to the idea of communication from the employer to the employee on maternity leave. I mean, how many people want to be in touch with your work team when you're on maternity leave, or your supervisor on a regular basis because they're part of your maternal mental health program? So right, that's maybe not what everyone's actually looking for, but there are ways for employers to institute these programs, and there are a number of new tech platforms that are doing this work specifically within the employer space, and I think that's really exciting. What I'm particularly passionate about and cognizant of in that conversation about maternity from as a clinical experience, as a psychosocial experience, as a physiological and emotional experience, all of these different aspects of maternity, the employer model doesn't necessarily support or have the support components it needs to touch on all of those areas. And so that's something to be mindful of, is that in order to really provide a comprehensive solution, you've got to balance what can be done from, frankly, like employee benefits or employee perks program standpoint with what the health system is in a position to provide and mandated to provide. So that's sort of an overarching way to think about it, is that I don't think that we should be expecting employers to actually do all of this work, in that, not to say that employers should not fund this. Absolutely, more work needs to be done on the maternity experience for employees. Sorry, this is how complicated this is, right? Like, we want benefits, we want leave, we want paid leave, and we want support for people in the workplace. We also need to make sure that we are not passing this over to employers and expecting that the clinical services and clinical supports and social and community-based supports that are integral to a comprehensive maternal and infant care program are going to be provided by that employer. Because oftentimes the employer is not going to connect you to your local WIC center. They're not going to say, oh, you know that there's Postpartum Support International. They're going to say, here's an app. And hopefully within that solution you have what you need there. But I think this is the stuff, you can see I wrestle with this, because I'm always looking for that right balance. And our product fits into the healthcare stack for a reason, because that is where value-based care programs are going to come from the outcomes that are related to this work on the clinical model. When we can show that this work actually changes the risk model, it changes the cost of care, value-based care becomes a reality for everyone.
But I think for first and foremost, my job is to make sure that our population is informed of the legal constructs that are in place, right? Legislation that you have certain time, you have certain areas that are supposed to be provided to pump. You're supposed to have all of these things. One of the things that I personally do for my patients is my 1 month visit. I know it's going to sound crazy, but my 1 month visit is, how do I get mom back to being a woman? Kind of thing. And I ask about, sexual protection. I talk about going back to school, going back to work, and I start coaching on, okay, we're going to pump, we're going to store. What's your plan? Have you talked to your employer? What are we going to do about breastfeeding? What are we not going to do? What are we going to do about childcare? And I make it part of my plan, because if I don't do that, I find that once FMLA is done and all of the other things are done, I have patients coming back at my 2-month visit, 4-month visit, and we don't have a plan in place. For me, breastfeeding is really important, and breastfeeding stops, and kind of all of those things. So I make it part of my visit to talk about it and to coach about what are the legalities, what should happen in school, what should happen in your workplace, what can I do as your provider for your child to help support? Should I write a letter? What can I do to help you?
All right, well, I think we are out of time. Obviously, you've heard a lot of really great ideas and great programs here, and there's still a lot of work to be done. I know some of these questions might be also tackled by 2020 Mom is having a webinar series. We don't know exactly the dates, right, but they're coming, on hospital programs, covering, some more of this material in more detail, and that should be very instructive. I just want to thank all of our panelists and all of you for great questions, and I think we're going to take a 15-minute break.
We have a break. Yeah, we want to also just say thank you to you too, Pam. We can't wait to see what you write about in maternal mental health, right? All we'll be sharing those articles and news articles widely.
Hi, everybody. I am Kay Matthews. I am the founder of the Shades of Blue Project. I am a community organizational partner with 2020 Mom. I also opened up the pre-forum with our Inspire Method training. It is designed to help break cultural barriers in maternal mental health. Today I have the pleasure of introducing Dr. Lusting. He will explain why loneliness is a critical emergent issue and how loneliness is linked to maternal mental health. Dr. Stuart Lusting is currently the National Medical Executive for Behavioral Health at Cigna. In his client-facing role, he engages with clients, provider groups, and other stakeholders about Cigna's behavioral health care business. He also manages a team focused on addressing individual customer grievances of importance to Cigna clients. A board-certified child psychiatrist, he previously served as lead medical director for child and adolescent care for Cigna's behavioral health business. He leads an ongoing effort at Cigna to disseminate health services research via peer-reviewed journal publications and presentations at conferences. These efforts have recently yielded several peer-reviewed publications. Cigna has also recognized the teams led by Dr. Lustig that contributed to these initiatives with Cigna's prestigious Quarterly Champion Award. Please welcome to the stage Dr. Lustig.
Thanks very much. So just a reality check here, folks. It's 3:30 in the afternoon. I want to thank the organizers for not making me the after lunch speaker, at least. Although I, for one, am still recovering from the 5 mountains of guacamole that I ate with a whole bunch of those Dove Pillow chocolate chasers. Delicious. So, I see a few empty seats. Most people are still here. It does feel just a little bit lonelier than, than before, but we will get through this. Now, you may be thinking, what does loneliness have to do with maternal health? And I want to answer that question, first of all, by showing you, I think a visual will be helpful here, so let me just pull this up. So this is a picture of my daughter there. She's the one on the left, which you can all clearly see. Even those of you guys back there in the cheap seats, I think you can see her. And you can tell from the photo that she's half Asian. And the reason that's important is because my wife's from China, and in Chinese culture, it's very common around the time of a birth for the extended family to come and help out. And so her parents came, and they cooked, they cleaned, they did everything. The only thing we could not get them to do was breastfeed, but they did everything else for her. And then when they left, it was just my wife and I and our nonverbal daughter just kind of looking at each other. And it was actually a pretty lonely period, particularly for my wife, who had not gone back to work and didn't, fortunately, for a couple months after that. And I will tell you that when you are my age, I know I look about 26, but I'm actually a few years older. But when you have kids when you're 26 or 32, everybody's doing it, right? I mean, everyone's having kids. And they... you've got a whole cadre of people to support you in this, because there are a whole bunch of new moms just like you. When you do it when you're in your late 40s, people look to you with gratitude because they can give you all of their hand-me-downs, but that's about it. So very lonely experience. And so I want to talk about loneliness in the study that we've been doing at Cigna. We've been very interested in loneliness, and I'll talk a little bit about loneliness among moms as well. And you might ask yourself, well, why would a company like Cigna, which is interested in health services and products, be focused on loneliness? And the answer is simply this, that when we look at the literature, we find that loneliness is related to a whole host of psychological and physical problems, and whether it's stroke or heart disease on the medical side, as it were, although, as we know, body and mind are connected, but just to create an artificial divide, or whether it's depression, anxiety, dementia on the psychiatric end of the spectrum. Loneliness is a common theme that is associated with all of these things. So anything we can do to understand this phenomenon better helps us take care of people. And so we have done 2 waves of studies, and I'm going to show you just a few slides to highlight some of the data from these slides. And there are 3 numbers on this page. 61%, which is the number of people in our survey this time around who identified as lonely using the UCLA loneliness scale. And this was based on 10,000 Americans ages 18 and up across the United States. This was 7 points higher than the number that we got about a year and a half ago when we surveyed 20,000 people in our initial survey. So people were, a significant number of people, over half, were lonely then, and we see more people who are identified as lonely now. 24%, and this is the number here, that say that their health is fair or poor. Now, this is a self-report measure, but the reason that this is significant from the standpoint of loneliness is because this variable is associated with loneliness. If you believe your health to be fair or poor as opposed to good, very good, or excellent, you're more likely to be lonely. And the final number, 90K, that's the number of hours that we spend over the course of our lifetime at work. And I know what you're saying. You've done the calculations in your head right now. You're saying, I work way more than that. Probably everyone in this room does work way more than that, but assuming a 40-hour week, 40 hours, right? But assuming a 40-hour week, that's the number that you come up with. And we focus particularly on loneliness among the workplace and among people who are working and in the workplace for this study. So let me show you just a few more numbers. I'm going to go to the bottom two because I think those are the most interesting, quite honestly, and most compelling and robust. What we found in terms of age was a repeat of what we found last time. And this was a very surprising finding. Every time someone moves into a different generation, they get less lonely. So the youngest people were the loneliest, the people who are 18, 19, 20. By the time you get to be 70, let's say, your grandmother, who may seemingly be isolated and no one's visiting her anymore, and she's not on using technology in the way the young people are, but surprisingly, older people were less lonely, and there was a monotonic decrease in loneliness, every single generation being less lonely than the one before. Now, I think in some ways that's a good thing because it says that there's something about our ability as we age, or at least maybe before the onset of screens everywhere, there's something about our ability to figure out how to connect with people and have meaningful connections, even if we don't necessarily have someone right beside us. But the social media piece of this was interesting, and this is worse since the last study that we did. And think about this, because when you're home alone, perhaps with a new baby, and you're trying to figure out how to connect with other people, you may be relying on social media. And we heard a lot of very good opportunities in a recent lunch about how technology could help connect people and get people services. But here are the results of our study, that the more you use social media, the lonelier you are. Now, this is different from the previous study, because the previous study that we did, we found that there were heavy users and light users of social media. And although there were some nuances that we sorted out in the paper that we published in the American Journal of Health Promotion back in June, by and large, the amount of social media didn't seem to predict loneliness. What was associated with loneliness related to social media use was this. It was whether or not you thought you were using social media too much. Right? Think about it. So if you're that kind of person who thinks, geez, maybe I'm spending too much time on the screen, well, guess what? You're right. So, and that's a good thing, because that means you at least have some degree of insight into this. But this was one of our findings. I'd like to share with you just a few others here. Let's talk about women and loneliness in particular. And I'm going to scoot over there to the right side. It's hard to read. This says, moms of children under 6 years old and 12 to 17 years old are the loneliest. Now, we weren't able to look specifically at the peripartum. Sorry, I'm going to stand back here. So, although I'm nice to look at, I know you're trying to see the slide. So, although we couldn't quite look at the peripartum period specifically, that's included in this 0 to 6 group, right? So, if your kids are from 0 to 6, that is a lonely time for moms, and perhaps as kids get more independent and go off and do their own thing and discover social media with a vengeance when they're teenagers, that's also another lonely period. Not surprising if we look at marital status that widowed moms are the loneliest, with 76% of them identifying as lonely on the scale that we used. And those who are married are the least lonely, and other permutations of marital status fall somewhere in between. And then I'm not going to put too much stock in this middle number because it's not a huge difference in the scores, but I did want to show it to you at least, which is moms working outside the home being lonelier than moms who stay at home. So something to think about, particularly as we're very focused on the work environment. Lots of data about the work environment we could talk about. Let me just share a few things that Cigna is doing. So quick commercial alert, but I'll keep it brief here. So we've talked a lot about expanding access and capacity, and we'll probably talk a little bit about that in the next panel. At least I will if I'm invited to, or even if I'm not. We have a support line for veterans as well. A lot of them are isolated and lonely too. And then there's some things specifically focused on kids. So one of the things is a recent $3 million grant that Cigna has committed to, and this is part of our $25 million commitment over the course of 5 years to support mental well-being in schools. Now, there's not a specific program or mechanism, so funding alert. If you know any organizations, if you're part of an organization that works with schools, have them go to our website, specifically the foundation, so they can see how to put this money to good use. And finally, a school support line. So as someone who has worked in schools or with schools for many, many years now, I can tell you that school psychologists, guidance counselors are overwhelmed. Their caseloads are enormous, the needs are very complex, and so anything that we can do to take a little bit of burden off of them and get them into, and help get kids connected with a compassionate clinician on the phone, potentially a good thing. All sorts of legal issues to figure out on a state-by-state basis, issues of consent, issues of parental involvement and where the service is delivered, but we can get past all that and get to the good stuff behind this offering. So. A few other things I'd like to share with you. Important in our study, in both studies really, if you look at the lower right, work-life balance, those people who say they have a good balance are less lonely. This is comparable to our previous study in which people who said they got the right amount of sleep as opposed to too little or too much were less lonely. People who got the right amount of exercise as opposed to too little or too much were less lonely as well. And people who, again, were physically healthy, as I mentioned earlier. The one thing that was interesting is there was no such thing, if you look at the amount of money that people make, did that match up to too little, too much, just the right amount? No, it did not. So they say that money can't buy you happiness, but our previous study showed that money can buy you friends at least. And people who were less lonely tended to make more money than people who were more lonely. So not a cure that all of us can necessarily access right away, but helpful to know. At work, since this was a work-based study focused on what's going on in the workplace, I'll share these results with you just quickly because I know we have a panel coming up in just a couple minutes. But if you were unemployed, you were the loneliest demographic in our group. Except for, again, the very young people. And relationships with coworkers mattered. So if you had good relationships with coworkers, you were less likely to be lonely at work. Part of building those relationships is being at a specific place for a particular time. So newer workers were lonelier than workers who'd been there for a long time, for example. Older workers were less lonely than younger workers, and so forth. So it's interesting seeing how these variables all come together. As someone who works at home, and many of us at Cigna do work at home, again, the just right thing, I keep thinking of Goldilocks and the Three Bears, which I've read to my daughter for the last 6 nights in a row. It's kind of the just right thing again. If you are telecommuting or working from home the right amount, you are less lonely than if you think you are commuting too much. Telecommuting, that is, or not enough. So again, remember, just right is how to prevent yourself from being lonely. Importantly for employers, and this is the part of the information that we share with them, lonely workers rate themselves as less productive, less likely to stick around, and more likely to take sick days or days due to stress. So there's a real cost to an employer of employees being lonely. So things that you can do, recognizing in others when they're lonely, asking people, making connections. The most basic thing you can do is having meaningful face-to-face interactions with each other. So at work, that may be stopping to have a conversation with someone who works in the office next to you as opposed to sending them an instant message. so face-to-face interactions, coming to events like this is important, because this is how we network, this is how we, yes, indeed, this is how we make connections that matter with people who care about the things that we do. At work, you can volunteer with others, you can exercise with others during lunch, all sorts of things to do to make those connections. Even basic things. The person at the convenience store down the street from me probably hates me by now, but I make a point of greeting the cashier every time I buy something there. And, not in a creepy way, like I don't hang out for 10 minutes while there's a line behind me, but just to have that momentary personal communication with someone, so it's not just, a brief transaction. So with that, I'm going to stop. I don't think we have time for questions, correct? We'll save it. That's the way to say it. We'll save your burning questions for the panel, which will start right now.
Well, hello, everyone. My name is Crystal McCauley, and I am very blessed to be a member of the 2020 Mom team. I have the pleasure of introducing to you our final panel of the day, which is a replication, actually, of a panel last year that was voted most popular. So thank you all for your feedback, and I'm sure you're going to enjoy this very, very much. I'd like to introduce to you our moderator. Her name is Jane Van Dis, and she's a board-certified OBGYN and medical director at the Maven Clinic, the nation's largest telehealth platform for women and families. She delivers babies at Verdugo Hills Hospital in La Cañada, and she's also a founder of Time's Up Healthcare. Jane?
Thank you. I'm actually going to introduce the moderator. I'm just like the introducer of the introducer. So I'm introducing Blair Dudley, and she works with one of my favorite groups, which is the Pacific Business Group on Health. And she leads the Transform Maternity Care program there, which focuses on care design, payment reform, and employer engagement initiatives to promote high-value maternity care. Awesome. She has nearly 10 years of experience in the healthcare industry, focusing on quality improvement, population health, and value-based care. Please lend a warm welcome to Blair Dudley.
Well, I feel very excited. I feel like I got an upgrade just now. I was like, ooh, I'm a doctor. This is great. So I'm Blair Dudley, and thank you for the lovely introduction. I lead PBGH's Transform Maternity Care program, and I want to thank the participant who was asking what can employers do to drive improvements in healthcare. This is your session. We are hopefully going to answer some of your questions and really have a robust discussion about what can both employers and payers do to further improvements in maternal health and in maternal mental health. So at PBGH, our program has been focused on a couple different program development solutions to succeed in a high-value maternity care vision. And that looks like promoting the use of nurse midwives, trying to reduce unnecessary interventions, not only looking at the cost to the whole system, but also trying to reduce unnecessary trauma to mom and baby and family. And then, of course, promoting, nothing says high-value care, like looking at not just the medical, but the mental health side of things. So we're actively and currently engaging in strategies on that front, including not only quality improvement, but specifically quality measurement. And we're actually working on a project right now in San Diego, so it's even better. I'm not sure who oh, great, thank you, was shouting out this work. So we're working on a project to develop a prospective maternity bundle, and as part of that work, we're going to be measuring the newer NCQA measures of perinatal depression screening and follow-up, so both the prenatal and the postpartum. So we're looking forward to sharing, hopefully next year, what comes out of that work. So we're going live with our bundle April 1st of this year, which sounds very quick in my mind. But in any case, let's, as they say, get this party started. So it's almost 4. And so just to get everybody excited, we don't have a lot of maybe dwindling energy in the room, so we'll use the mantra of Maternal Mental Health Forum. So I'm going to say, we can. You say, do more. Ready? We can. Do more. All right, that was okay, but we can. Do more. Okay. I was not a cheerleader, as you can tell. Okay, so I want to welcome our esteemed panelists up here. What we'll be covering today, like I said, is how employers can be powerful drivers of change through network and benefit design, consumer education, and working directly with payers and providers, and how insurers, both commercial and in the Medicaid space, can promote maternal mental health. So let me do a quick round of introductions so that we can dive into the meat of this work. So we are joined today by Rick Hecht, who has over 25 years of strategic leadership experience in the healthcare industry. This includes experience in hospital and practitioner settings, managed care organizations, health plans, insurance providers, and integrated delivery systems. He's been a behavioral health licensed California clinician for over 25 years and is the director of behavioral health at Willis Towers Watson, providing consultation and subject matter expertise to employers and organizations. So thank you, Rick. Second, we have Carol Mendoza, who leads the Global Health and Wellness Benefits team at IBM in the Human Resources Group. And Carol is a certified employee benefits specialist and earned her MBA right near here from the UCLA Anderson School of Management. Thank you, Carol. Next, we are joined by Jennifer Moore, who is an internationally recognized leader in the Medicaid and maternal child health space. 20 plus years of experience. Her work is really at the intersection of practice, research, and policy, and we're thrilled to be joined by her today. And then we have Pooja Mittal, who is a family physician and works as a medical director at HealthNet with a particular focus on furthering equitable care through a population health model at HealthNet. Thank you, Pooja. And last but not least, we are also joined by Stuart Lustig, who I will skip your introduction, not only because we've already gotten a lovely introduction of you today, so thank you very much.
I'd like to say of all the many introductions I've enjoyed over the years, yours is certainly the most recent.
Well, thank you. I'll take it. Thank you very much. So we're going to start with a little bit of a round robin, and now that we know a little bit about who all of you are, we'd like to hear a little bit about your organization and your role there, and give us a kind of brief overview of your focus on maternal mental health and behavioral health in general. So we can just start down the row. Rick, do you want to start us off?
I'm Rick Hecht. I am the director for behavioral health for Willis Towers Watson, which is a very large advisory, brokery, and solution consulting firm. They are the third largest brokerage firm in the world. They're in 140 countries, been around since 1828, back when I got my license. And it's really organized around 4 businesses. And the business that I work for is human capital and benefits. And within that division, there is retirement consulting, technology administration consulting, and then talent rewards, and then what I do around healthcare and benefits. And so my job is to support a whole bunch of consultants around the country who go out and talk to customers around their benefit design and different ways to keep their folks healthy. And I'm the behavioral health subject matter expert. So I've been there all of 8 months. So just trying to figure out what they do and what I do.
Hi, everyone. Thank you for hanging in there, for staying here for the last panel. As was introduced, I'm Jennifer Moore. I'm the founding executive director of the Institute for Medicaid Innovation. The Institute is a 501c3 nonprofit research and policy organization. We work with a lot of different Medicaid stakeholders that oftentimes do not work together, but bring them together around salient issues that they all agree are important. Maternal depression and anxiety is one of them. And one of the projects that we're leading right now is funded through the Robert Wood Johnson Foundation. And we're looking to transform health system and payment reform. And what we're doing is we're bringing together teams as part of a learning collaborative. And the teams consist of state Medicaid agencies, Medicaid managed care organizations, and provider groups, and members who are enrolled in Medicaid. And through this process, we have identified 7 states. And the 7 states, the teams that I just shared with, have identified areas that have disparities or issues of equity that are at the top of their mind. 2 states identified maternal depression and anxiety amongst all the issues in Medicaid. And so we're going to be working with them over the next 3 years to identify how they address, like many people brought up earlier, the issues of payment, the issues of how do you do this within Medicaid? How do you bring together these different stakeholders to advance this issue? And as if this is of interest to you, you can definitely check us out on our website. We've got more information. We're funded through the California Healthcare Foundation to do a comprehensive report, doing a national scan to look at what's going on in the space of maternal depression and anxiety. We have an annual survey where we collect information from all of the Medicaid health plans to get a sense of what's going on in the industry. And that's just a snapshot of some of the work that we're doing in this space.
Hi, thank you. I'm Carol Mendoza. I am the employer on the panel. I work for IBM. Does anyone not know who IBM is? Probably, okay. I am responsible for health benefit strategy globally for our 400,000 employees. And I'm personally passionate about this topic, and I think we can do more to address maternal mental health for the half of the U.S. population that is covered by employers.
I'm Pooja Mittal. I'm a medical director at HealthNet, and I actually work in the PPO line of business. But about half of my work is looking at population health overall and thinking about how we can provide the right care for the right person at the right time. And in that area, and also building health equity into that, is where we've actually really been able to start taking a look at maternal mental health and how that fits into the whole family and the whole structure of healthcare, where otherwise healthcare is quite siloed and we end up looking at really the individual and not sort of the long range effects that we know mothers have on the rest of society.
As a child psychiatrist, I'm particularly interested in the well-being of children. And one of the things that we've learned from William Beardsley's work almost 2 decades ago in preventive interventions is that the best way to prevent depression in kids is to treat it in mothers. So I'm particularly interested in this population as well. And I can tell you in my role at Cigna, which is to interface with many of our clients who are large and small employers, that everybody is aligned on this. We want people to get care. You all want patients to get care, and none of our employers who are our clients want people knocking on their doors in HR saying that they can't get in to get the treatment that they need. So I'm here to really learn from all of you and get some takeaways that I can bring back to our provider relations teams and strategies to share with our clients potentially as well. So looking forward in particular to this panel.
Well, thank you, everyone, very much. So I want to start us off and get this question back to you, Jennifer, actually, so if we can hand a mic back down to you. So you mentioned your, I believe, 2018 report to give really a comprehensive overview of the impact of maternal behavioral health disorders. And I would love for you to share with us, even just briefly, how those maternal mental health disorders can affect not only birth outcomes, but also behavior patterns in the child.
So is this on? Hello? Oh, good. So thank you. Again, I have to thank Stephanie for believing in the work and helping to support through the California Healthcare Foundation, looking at this nationally, but also honing in on California. I cannot emphasize enough that California is an incredible innovator in terms of maternal health, full stop. And to have such strong support from foundations in this area really contributes to that success. So thank you, Stephanie, and others in the room who may be representing that area. So this morning, a lot of information, a lot of data was thrown at you about the impact on mom and baby, but some of the key pieces that we found as we were looking at the data and the research that I didn't necessarily hear brought up, but was underlying the presentations, is the impact on preterm birth and low birth weight. These are big issues in the Medicaid space, which all of you are very familiar with. We also know that maternal depression and anxiety has an increased risk of child abuse and neglect, developmental, behavioral, physical conditions and issues that arise. And we also know, especially in the Medicaid population, that there's an increased risk that that child will be put into foster care. And foster care is a really important topic for us to consider as we think about this issue. But I also wrote down a couple of stats that I just want to throw out there because I love numbers, I'm a researcher. But 19% of new mothers experience depression during the first 3 months of postpartum. And then of low-income women, I'm on this panel, I'm going to talk about Medicaid the whole time, so get used to it. Greater than a third of women in Medicaid do not receive treatment. That is not acceptable.
Thank you very much, Jennifer. That's really helpful thank you for starting us off and looking at this global view of mom and the whole family unit. So now I want to really turn first to our employer voices, and Carol, I'll start with you to say, is maternal mental health a priority for employers?
Yeah, it's a good question. I don't think that maternal mental health is a priority for employers, but I think maternity care is a priority and mental health care is becoming a much bigger priority. So there is an opportunity at that intersection to get employers involved in this issue.
Thank you. Well, and Rick, I wonder if you can weigh in as well, just kind of telling us what trends you're seeing.
I agree. I think just mental health in general has become a real priority for employers. We've seen a 30% increase in suicide in the last 20 years, 47,000 people a year kill themselves, 67,000 overdoses last year. So they're sitting up and taking notice. It's really, mental health for the first time in my 30 years in the industry has really become part of the national conversation and really part of the sort of global zeitgeist in general. This isn't just an issue that we're dealing with here in the States. As far as maternal mental health, I haven't really talked to customers about that. I don't know enough about it. I know that the work that Joy and this organization and the people in this room are doing is incredible. I have been blown away and humbled by just the brilliance and the passion that I've been hearing all day. So I appreciate that, and I've learned a lot from you guys.
Thank you both very much. So I want to ask the same question of our health plan participants. And Stuart, perhaps we can start with you to say, how is this a priority amongst health plans? And then Pooja will come to you next.
Yeah, well, I think if you were to ask anyone at our organization, what's the best job that we have in all of Cigna? We've got 75,000 people or so working for us at this point. The people who would probably stand up first to say, I've got the best job, would be the frontline clinical case managers who are engaged in case management and coaching programs. And we have in behavioral 900 people in operations. Many of those are case managers and people who are on the phone directly with moms. Moms to be. We have a healthy moms, healthy pregnancies, healthy babies program where moms can call in and we call out to them. They can get anything from information about what foods to eat, what foods to avoid, how to find a good birthing class, where to find out about breastfeeding, delivery questions, all of that. And importantly for this group, they do screening as well for depression, and they know when to refer to our other group group of case managers who are sitting in our behavioral organization. So I think our biggest priority is reaching out to people who are in need and following up with them after pregnancy as well.
Thank you.
So at HealthNet, we have a similar program that we call Start Smart for Baby that's really focused on pregnant women and reaching out to pregnant women. But I would agree with you, actually, that I don't think that maternal mental health has necessarily been the top priority. I think maternity care is really important and mental health care is really important. And those things are still quite siloed. And as we start to move towards more thinking about populations in general and healthy people and less healthy people and what do they need, insurance companies are starting to notice, right, that the woman's health affects the family's health, that she's often the decision maker about what health plan they're going to choose, right? She's often the one making that decision. And so we have to make sure that we're paying attention to her health if we want her to be happy and if we want her to stay with our plan, stay engaged in care, and bring her family in for care.
Thank you both. Well, and to build on some of the things that you've just described about these programs that are happening within both of your organizations of Cigna and HealthNet, I want to ask both Carol and Rick. So, Carol, how much do you know right off the bat? You know, the resources that are available at your plans. Is that with your role being so broad and maybe healthcare is a piece and maternity care is a smaller piece beyond that. How do you find it easy to know the programs available, or what are some of the challenges you see there?
I think the typical employee has no idea the vast array of programs that are available, and finding the right program at the right time is a real challenge for employees too. And if you think about, if I try to communicate with you about all of the wonderful things that we have available, if it's one more thing in your email box, if it doesn't resonate at that moment, you're going to delete it. So I think we have an opportunity as employers to find different ways to outreach to moms who are in need. And as an example, something that we did when I was with a prior employer was to send out baby kits to moms who were pregnant, who self-identified and said that they wanted them. We didn't want it to be creepy, but included information about postpartum depression, maternal mental health, just to raise awareness so that they could think about if they weren't feeling at their best and thought that something might be wrong, they could then outreach to the EAP.
I love what Carol said. It's sort of the broken record that I go out with, is that you have to keep this in front of people all the time. A lot of organizations during Mental Health Month will send out a flyer about their EAP, and it's sort of like if you're in the market for a car, every commercial that you see on TV is a car commercial, but the other 11 months a year, you don't notice them. They're still there. It's the same, keeping things in front of people. The health plans that I meet with, almost all of them address maternal mental health care in their condition management programs. They actually screen for depression across most condition management programs. So it's encouraging. We go out and we do chart audits and we see the notes and that people are really following through. And a couple of the health plans have really customized programs where they do outreach and screening, even postpartum. So it's encouraging to see that it's happening out there.
Thank you both. Well, and now I want to come back to Stuart and Pooja, because you gave us a kind of a general overview of some of the programs that are happening at your organizations. And now I wonder if you can touch on some of these innovative solutions that are kind of newer and have developed more recently. What are some of the takeaways that you want us to know about these new programs or new policies?
So one of the new programs that we're launching specifically to address this issue is Wellframe, which is a digital platform that is an app-based platform for your phone that's actually patient-facing, that allows the patient to interact with the health plan directly. And so one of the first programs that we're launching is the maternity care program. So it offers the patient direct contact with the case manager who will outreach and evaluate their risk for an array of different things during pregnancy, but also postpartum depression or maternal depression. And it'll provide an entire educational suite about all kinds of things that are pregnancy related. And it also will offer her an opportunity to sort of have a back and forth with somebody directly at the plan about whatever she needs. So our case managers are nurses, and so if it's something that's medical that needs a clinician to respond, the nurse will respond. And we also have program coordinators who are part of that conversation. So if she needs, for example, some support getting connected with a therapist in her area, that person can then step in and help. And she can access all of that through her phone. Because I think one thing that's maybe a downside of many of the case management programs that health plans use is that they're very telephonic based, and not necessarily that convenient for the member, right? It's like I was in a case management program for my pregnancy that was high risk, and I remember I would get a call at like 2 p.m. Can you talk to me now about your high risk pregnancy in the middle of your workday? And it's not always that easy, and I think it's much easier to allow patients to outreach to us when they have access.
You know, in addition to the Healthy Pregnancies, Healthy Babies program that I mentioned, we also have a high-risk pregnancy case management program as well. We use the PHQ-9 to screen for depression in that program. But following up on the access issue that you raised, the other area where we've been quite focused in the last few years is virtual behavioral health, telehealth as we think about it. And although it feels very new and exciting to all of us, you know, the Australians were way ahead of us 20 years ago. They had figured out they've got this massive continent, and the only way they're going to serve you know, the 20 million people spread out over this massive continent, or if they could get people to connect virtually. And so we are catching up at this point. Being a researcher at heart, I am particularly interested in a project that we are now starting, which is to look at actually who's using this. Is it, for example, those lonely young people, or is it the isolated older people that we were talking about before? Is it the new mothers, for example, or is it folks who are pregnant and may have difficulty with mobility or precious little time, who are taking advantage of the extra time in the day saved by not having to commute to see your clinician. And also rural versus urban, who's really using these things. So I'll have more on that next year when I see you all again, hopefully, but we're tracking that now. So that's also where we're very hopeful that that's going to help a lot of people to get care more easily.
Thank you. So, so now I want to ask a little bit more, Carolyn, I'll put you on the spot again, because I want to know, what would you and you know, some of your peers and other engaged employers like to see change in payers to address the growing maternal mental health challenges?
I think we're actually very aligned, and it's reimbursement. I think some progressive employers have started working with EAPs that are reimbursing at higher rates to draw more people into the network. So people who won't connect with anybody else, won't contract with anyone else, will work with these EAPs. And it's not only about having more people in the network, but also doing more outreach. So I'll use actually my own personal example. I called the EAP number when I was struggling, and I got a list of 3 providers that I could call. Nobody took my call, nobody returned my call, and so then I had to go back for another list. That's incredibly frustrating for women who are struggling with this. So some of these EAPs are helping to make those appointments for moms, and I know that Cigna's doing some work around this as well, so that they're not having to deal with just one more bit of friction or one more point of frustration. So I think reimbursement, and we're willing to pay more, especially if you tell us that it's needed, and we want to make it a better experience when moms do actually reach out.
Can I follow up on that? And I'm glad you said what you said, because one thing people may not realize about companies like Cigna, for example, is that most of our employers are large employers who are not paying us to assume risk. If you're IBM, you guys are huge, probably bigger than we are, right? You can afford to underwrite the risk for your health plan, but you're not in the business of managing that and being clinicians. And so it's actually IBM's money on the line, quite honestly. And so for you to say, and this is helpful for us to know, yes, we want to make this available. Our obligation to our clients is to provide an affordable network, a robust network, and we check with the people in our network every year to make sure that they are still accepting patients, or at least that they haven't retired, or even worse, died, because that happens. So, but we want to, we need to offer a value-based network, but also, we don't want any noise around people not being able to get in. So when you guys say, make it happen, that's helpful to us to know.
To let you off the hook a little bit too, I will say that employers for a long time have been really focused on how do we drive down reimbursement rates because we don't want to pay any more for health care. It's becoming too expensive. But the comment that was made on an earlier panel about cardiologists, and we're not talking about cardiologist reimbursement rates. We just want to make sure that there are enough cardiologists in network. We should feel the same way about mental health professionals.
So I agree with all of that, and as Dr. Phillips eloquently put it earlier, they've been paying crap for many years. What I got 28 years ago in practice was not a whole lot different than what they were paying 5 years ago. But money isn't going to save it by itself. So right now we have such a shortage of providers across the country because they could go do other things like be a Walmart greeter or something and make more money than we were getting after paying office and billing and insurance and all of that. Today, 110 million Americans, about a third of the population, live in an area that's designated as having a provider shortage. Psychiatrists, 50% of the counties in America don't have a psychiatrist in them, 50%. Stuart happens to be a real unicorn in that he's a child psychiatrist. You can't find them anymore. People have gotten away from that, and it's been because of the money, but bringing money back in or paying higher rates. So there are some organizations, we talked a little bit about, there's one that sort of reinvented EAP, and they're paying $150 a session instead of 60 or 70 bucks. And what that's doing, though, is actually pulling people off the Cigna panels and the United panels, and it's actually making the problem a little bit worse. So we've got to find some other ways to treat people, and we've also got to get people back into the profession.
Hear, hear. So thank you. I want to ask a question because we've been talking a little bit about how network design makes a big difference and these kind of logistical barriers and providers in network and things like that. And I want to merge the kind of commercial side of things with the public and Medicaid side of things and ask the question. We'll start commercial. So Carol and Rick, we'll start with you and then head to you, Jennifer. But I want to ask the question of how do you as a purchaser think about not just the kind of system level considerations, but how do you get that individual motivated to get themselves to care, particularly in this kind of space at a hard, vulnerable time? And how do you see benefit design as potentially a lever?
I think awareness of the resources that are available is incredibly important, and then breaking down as many barriers as possible to care. And one thing that I think some employers are starting to do too is to increase the number of visits that are available under an EAP. Many large employers have gone to high deductible health plans. So even when you can find someone in network, you're still having to pay 100% of the cost until you've met your deductible. So the more that we can provide outside of the health plan in an EAP, the more access there will be to, hopefully quality care at no cost.
Yeah, I agree. There are really So 60% of people that experience a mental health disorder in a given year don't seek care at all. And there are really 4 levers that we have to pull. And one of them, the first one, is awareness. People, one, don't understand that they have a mental health condition. So there are some vendors that we've been working with out in employers that go out and really drive home. If you guys want to Google something cool, it's called Angst, the movie. And this is a woman who was a film producer that started making some mental health films. And so we've used that with some customers to really say, hey, this is what anxiety looks like. Awareness is one. Breaking down stigma. Stigma still exists today. So going out and developing anti-stigma campaigns and communication. And again, it's got to be all year long. The third one is what we're talking about with access. Just providers are looking at innovators and disruptors as they're doing it a little bit differently so people get care. And the last one that Carol just mentioned too is cost. So if you have a high deductible health plan and you're feeling depressed and you want to go get care, but it comes down to you paying for the therapist or putting food on the table, your mental health is going to take a back seat. So we're seeing a lot of employers, working with a lot of employers as well, to sort of reimagine their EAP, to find new ways to brand it, to promote it. This is a no-cost service to increase the visits. So if you can pull those 4 levers, people will start getting the care that they need.
Thank you. And so, Jennifer, now if you could give us a little bit of insight. I know you were mentioning earlier that Medicaid moms in the 4th trimester are accessing care. There's not as much utilization as you'd like to see. So, thinking about it from that standpoint, what are how could you? What would you like to say to Medicaid fee-for-service and managed care plans alike, or separate, however you want to describe it, to encourage more utilization, particularly in this postpartum period?
Yeah, I think we need to recognize what the life of someone who is enrolled in Medicaid looks like, and it's very different than someone who has employer-sponsored health insurance coverage. So a lot of the comments that were made resonated with me, who has employer-sponsored insurance. But when I think of the patients I work with at the clinic, I work still at an FQHC in DC, and getting them to that postpartum visit is really a challenge, and they're dealing with a lot. They may not have a bus ticket to get in. They may not have support at home, and may not be in a place where they're ready to pack up the baby and bring them in. And so going back to the report again that was funded through California Healthcare Foundation, when we did our environmental scans, what we noticed that the best practices and innovators in this space for the Medicaid population, they really focused in on home visiting programs. Instead of expecting her to come in, why don't we go to her? And investing in that step, looking at the role of community health workers, looking at the role of the doula if they started prenatally, and establish that rapport and that relationship, and having that set of eyes in the home to see what really is happening and listening and connecting to resources and support. We also know from the report that moms are more likely to go to the first pediatric visit, but not necessarily their postpartum visit in the Medicaid population. So the pediatrician becomes a really important set of eyes and ability to do an initial screening, and making sure that we have the funding and reimbursement to support that, and that the pediatrician has the capacity to share that information to other providers as a follow-up for moms. So there are opportunities, but reducing those barriers in Medicaid is important. And you mentioned extending Medicaid and making sure that women have access and coverage through that first year postpartum. We know that over 50% of maternal mortality occurs in that postpartum period, and let a lot of women in the U.S. lose coverage in Medicaid after 6 weeks. So one of the quotes in the report that Pooja and I actually worked on, it's quoting someone else, but what would it look like for women not only to survive but thrive? And are we giving women enough chance, especially those in Medicaid, if we kick them off after 6 weeks? Especially if she has a newly diagnosed maternal depression or anxiety. And then we say, okay, good luck, and then we leave her. So looking at that and thinking about what that looks like for the program.
Thank you. So I have another layer to this, and I again want to turn to Jennifer, you, and Pooja on this. But just to dig a little bit deeper, what are some of the either institutional or cultural challenges that you see to delivering patient-centered and culturally aware fourth trimester care, and maybe some ideas around potential solutions to tackling these barriers?
Yeah, I think Jennifer hit on a couple of them already. I think home visiting programs are really important for that reason, because they really allow us to meet the woman where she's at, instead of having to push her to come into a system that she may not feel well supported in. I think other things that are really important, one that works really well is group visits, so group prenatal care and also group pediatric care. So I used to work at San Francisco General Hospital, which is part of UCSF, and we used to transition women from group prenatal care directly into group parenting care. And it would be the same group of women who had been together their entire prenatal care, and they would come in as parents into the group, and we would provide dyadic care, right? So we would see them both at the same time. They could bring their other children, to your point, to the groups, even though that wasn't truly, along with the model. We would just give them something to do and feed them, and that really allowed for women who were at the same point in their lives, in terms of around the same age babies, to connect in a really different way and be able to support each other in a really different way, and spend a lot more time with their providers. So I think group prenatal care and group parenting care is really important, or group dyadic care. Those are a couple of the things for me that come to mind, and I think there's better things that we can do as a system to support all of those things. So we really need to think about how could we bundle an entire episode of care, so that we are thinking about providing, what does it look like to provide care for the entire first year of life for mother and baby, and how could that be paid for in one episode of care, just like we pay for pregnancy as an episode of care, right? And so I think we need to really start thinking a little bit more broadly about what does an episode of care look like for a mom and for a baby pair.
Thank you, and I wonder if either one of you can jump in as well, because I think one of the things that we've heard in our work, and I'm sure you hear in yours, is providers' ability to understand what their patient is going through, and for the patient to see, wanting to see themselves reflected in their provider, either on the level of race or ethnicity, language, and hopefully that provider is somebody who's specifically from their community, ideally. But how do you think about, what are some of the strategies, do you think, to give providers tools to, if there is a mismatch in that provider and that patient, trying to, again, give that culturally aware, or at least conscientious care? So,
yeah, returning back to the report again, I mean, it's perfect. Again, looking at best practices and innovative approaches. When I think about back to when I was training to be a clinician, the term culturally competent care was being used. And essentially it encompassed knowing what types of food someone would prefer based on their race, ethnicity, religion. And that was it. And we've definitely evolved, but think about the cohorts of clinicians out there who have never been trained in this space, truly trained to understand, respect, listen to cultural differences. But again, the report, one of the things that we thought was really interesting, that a lot of community organizations and also health plans noted that really helped to transform their ability to connect with their Medicaid members, and also address issues that may not have been explicit, but they understood, was by making sure that everyone within their organization was trained. That means the person who answers your phone goes through the same training as the clinician or the care coordinator or whomever, and it has to be embedded into your own organization before you can expect it to be brought out into the world and shared with others. And I thought that was a really striking point and something to share and to consider. I know that for large corporations like IBM, this is like, yeah, we do this all the time, or Cigna, but there's medium and smaller size organizations that may not have thought of this, and integrating that is really critical.
Jennifer, I would also add, we really have to pay attention to the pipeline, right? Recruiting more people of color into the profession, it matters, and that's something that's much broader than this discussion, so I'll just leave it at that. And then I think that there's other ways of thinking about co-located care that really pull in the community in partnership with the medical setting. And so the JJ way is one that comes to mind, and that's something maybe you guys could look at later, but there's this woman named Jenny Joseph who's doing this incredible work in Florida where she's bringing together the clinicians and members of the community into the same space to take care of that family, and providing this sort of wraparound prenatal care that really hits all of those points in making somebody feel like they're in a space where they're understood and respected and receiving good care.
And two other examples, but I'm going to let him pass on, but like Mama Toto Village in DC is transforming care in DC and thinking about it from a cultural perspective. And then Birth Detroit, this is a community rising. They're creating a birth center, and the community is defining what that looks like and how it reaches their community. So I highly recommend checking out both of those two.
You know, I think it's fair to say there probably are more female than male doulas out there. And when it comes to mental health as well, many women would probably prefer, if they could, to see a female provider. And one of the things that we're quite careful about, or that we monitor, is our balance of male to female providers. And I can tell you, in 2019, almost 80% of our master's level clinicians are women. For psychologists, it's just a little bit shy of 70%. And for psychiatrists, whether MD or DO, the number has been steadily increasing from about 37% in 2015 to 40% in 2018 to 43%, so we're moving in the right direction, in 2019. And so, again, something that we hope will help people to feel comfortable when they are able to connect with a clinician.
Thank you very much. That's certainly something that you think about from a consumer perspective, and it's great to hear how Cigna and other organizations are trying to meet the needs. So Pooja, I want to ask, I know you touched on a little bit about some of the kind of provider-centric strategies, but I want to ask, as a payer, what are the things that that you've seen and that you're doing at HealthNet to promote equity?
Yeah, so HealthNet has put a really big focus on equity in maternity care in the last few years, actually. And so just to give a little bit of background in terms of some statistics, in Los Angeles, the most recent data shows that African American women have a 4 times higher mortality rate than any other race. And they have, African American infants have a 3 times higher mortality rate than any other race in LA County. So it's quite striking, those numbers. And so we've put a lot of resources towards really addressing that huge disparity. So we have 2 active projects going on right now. One is our HealthNet doula program. It's in flux right now in terms of what it's called, but we're still calling it that for now. This is a program in which we are providing around 100 African American mothers who are on Medi-Cal in the Los Angeles area with African American doulas from within their own community through a community-based organization. And they're community-based doulas, which means that they have additional training in the social determinants of health and how that affects maternal outcomes. And they are going to be providing prenatal visits. They'll be there for the birth and for a few hours postpartum, and then they'll also provide 3 postpartum visits. And we're pretty early in our pilot. It's a about 1 to 2 year pilot, depending on how long it takes to get all the patients in, but we have really amazing outcomes already. We've had 18 births, and 17 of them have been vaginal births in an area where 50% of African American births are usually cesarean sections. So our initial outcomes are really promising, and we're really excited to see sort of what comes out of it at the end. Another major initiative that we're funding is an initiative called Communities Lifting Communities. And this is an overall initiative that's looking at improving and having healthier births and safer births for all Black and all other families in Los Angeles County. And so this is an intervention that occurs at 3 different levels. One is the clinical level, one is the community level, and then one is the institutional level. And so we're doing work in a lot of different areas, partnering with the iDream organization with Coach V in the back and the Hospital Association of Southern California to do implicit bias training in some of the hospitals, to have some interventions within the hospitals where actually some of the hospitals are at the tables with us and sitting down and having conversations about why there's a huge disparity and what they can do about it at each institution. And then we're also going out into the community and having folks from the community weigh in on what would help improve those things and take action together.
Thank you very much. That's really exciting. And so I want to make sure we give enough time for folks in the audience to ask questions and share your reactions. But before we get to that, I do want to ask a happy question to kind of close this out a little bit, which is, if you had a magic wand, you could change anything about the system in terms of payment, care delivery, policy, or consumer engagement. And some of you have already mentioned a couple of these strategies. What would it be? And we can go in any order.
I think I kind of covered. Mine would be the levers, just to get people that need care, care. When I go out and meet with employers, so part of my job is vendor management. So we go out and make sure they have the right partners, make sure they're getting everything out of that relationship that they should be getting, go out to bid if we need to. But for me, if you really want to impact the health of your employees, vendors matter a little tiny bit, but it's the culture at the workplace. So for me, being able to go out and address stigma, increase awareness, make sure your managers know how to recognize, respond, and refer people who are in distress. It really starts at the culture at the workplace and probably outside of the workplace as well. So that's, I would want to see more focus on culture.
I'd be remiss not to say innovate as part of our name and Institute for Medicaid Innovation, but I would say innovate and partner and don't give up. So the initiative that we're working on right now, where it's a learning collaborative and team between the state Medicaid agency, the health plans, and the provider groups, is probably the hardest project that we have undertaken at the Institute for Medicaid Innovation. It is not easy to transform payment, and it's not easy to transform payment in maternal depression and anxiety in Medicaid, but we're doing it and we're not giving up. And I would say for everyone, just continue to innovate, continue to partner, and don't give up.
And for me, I would say improving access to care for moms at a reasonable rate for them and eliminate as much of the friction in the system as possible so that they can get the help that they need for the lowest cost possible.
Yeah, I mean, I would say I would piggyback on both of those and say I think the biggest issue is really siloed care. And we're all in this room and we can agree on what we'd like to see. And so really pushing for that cross-sector collaboration so that we can break down some of the silos and really use all the work that we're doing to do what we all really want to do anyway.
Yeah, unfortunately, Carol took my magic wand and she said access, which is what I would have said too. And we actually are working hard on that. This quarter, we rolled out a faster access program, which for people participating in that program, providers participating, it means a callback to a patient within a day, a therapy appointment within 5 days, and an appointment with a psychiatrist or prescriber if needed within 15 days. And this is in 24 markets, or will be by the end of Q1, including LA, where there's certainly a strong appreciation for psychotherapy and the like, and then nationally later this year. So I'm absolutely with you on access, critical issue.
Are you reimbursing different in that express network to get providers to respond that way?
Yeah, we are certainly willing to where we've needed to, although what actually makes it worthwhile for the providers is knowing that there will be a significant influx of reliable patients who are going to come in. So, these are typically not mom and pop shops. It's larger clinics where volume is, where they're better able to accommodate volume and perhaps looking for volume. But we can certainly reimburse as we need to, as I mentioned on an earlier panel.
And just a follow-up on that, is that, growing the volume, is it within a lot of risk-based environments and contracts already, or just generally is the carrot to providers growing that volume and having that consistency?
My understanding is it's agnostic of where the risk is actually. Yeah, but
great.
Just increasing the access across the board.
That's great.
Yeah.
Carol?
Can you comment, Stuart, on consistency and what you mean by that, what they're looking for?
The funny thing about the way a lot of clinics run is if you call them up and ask for an available appointment, what they'll tell you is they're full, right? Or they'll tell you we don't have an opening for 4 weeks or 5 weeks. But if you actually look at who is coming in the door, they're not full. And part of the reason for that is there are a lot of no-shows, right? And particularly in a Medicaid type of clinic, right, where the rates can be up to 50%.
50% is the
50% is that the average, yeah. So a little bit less so in the world that I work in, but still fairly significant. And so the challenge, so the consistency is important, ensuring that people do walk in the door. And where the clinics have to do some work is to figure out, well, how do they handle no-shows? Do they have a reminder system in place? Most clinics do. Do they have a system for outreaching people on a wait list? Some do, some don't. But you can actually get a lot more people into a clinic than might first meet the eye if you can handle the significant vacancy rate, as it were. So that's what I was referring to. Yeah, thanks, Carol.
Well, thank you, everybody, for sharing what's happening within your organizations. And now I would like to open it up to the room to find out what are the questions that you have.
Hi, I have a question around, let's see if I can try to wrap it into a small question. So I have a pretty eclectic experience. I was an insurance broker, and then I went into the nonprofit world, and now I'm a administrator/clinician, so I'm kind of a unicorn. I grew up in MHSA funding, so I have a really different perspective. But as you guys are talking, and we're talking about people not showing up for appointments, we're talking about the billing not being effective, I'm just wondering about what are people talking about how we're going to engage people? Because if we're talking about a taxed workforce and our providers are really exhausted, and we're talking about people not showing up to appointments, then there's something that needs to shift with inside of that.
I agree we have to do something. One of the things I wanted to mention that is top of mind for employers is the changing demographic in the workforce, right? More than half the population today, the work population, are millennials and Gen Zs. Their incidence of depression, anxiety, even suicidal ideation is off the charts. And they access care a little bit differently than generations in the past. So we've got a lot of innovators out there. They're looking at different apps. I was talking about one earlier that I met with yesterday where the first session is telephonic with a clinician, and then it's more digital-based after that. You get assigned mindfulness and CBT. The therapist will text you throughout the day just saying, hey, how's your day going? So we see a lot of people looking at alternative ways to deliver care. We know for this, again, population that's about to really take over the workforce, we're going to have to do something different because, one, they consume differently, and two, because they seem to have a greater incidence of mental health.
And Rick, I know you mentioned earlier too that it really, part of it is the structures, but a lot of it also is the culture at the organization matters a lot. And so I wonder if you or Carol or anyone else actually on the panel can comment a little bit about, not just the family leave and paid family leave, those kind of policy things, but maybe things like flexible work schedules and because that to me, as a millennial, is really a culture piece, and honestly really drives my choice in where I want to work.
Yeah, that's consistent with what we're seeing with your generation and the Gen Zs as well, and that financial incentives aren't the thing that motivate them the same way that time off. The numbers on the millennials that are willing to take a job tomorrow, a different job, if they have that opportunity, is higher than we've ever seen before as well. So if you create a culture of caring where people feel supported, they have leaders that are empathic, and you just connect them. Stuart was talking about loneliness earlier. We chatted last week. I'm on my third attempt to write my dissertation, which is on loneliness and social connection. But when you look at loneliness in the workplace and you see the impact that it has on people's health, but also productivity, and the Gen Zs and the millennials are the loneliest of all, and now they're going out into a workplace where they don't have the skills to connect with people that impacts collaboration. If we don't start changing the culture, getting people to feel included, feel connected to the tribe, we're going to have a lot more problems than we have today. So that's why I try and focus on culture whenever I can.
And I would just like to go back to her original question. And one of the things that we do at the Institute before we start any project is we bring together people who essentially are going to be impacted by whatever the initiative that's intended to impact, and we ask them what they want. And so often we assume that we know, and then we develop something and we implement it, and then we ask, well, why didn't it work? And when we talk about care that's a cultural care that reduces stigma and bias and racism, like talking and hearing that story and that narrative and understanding what that means is really, really important. The number of times that a vendor will come to the Institute and tell us how great their product is and how they want to partner with us on a project, which we've never done, and there are some great vendors out there. But when it comes to maternal health, I'm really sensitive to this, and I always ask them one question, and none of them have said yes. And I said, how have you engaged women who are enrolled in Medicaid to design your product? And all of them are like, well, we didn't think about that, or we didn't, or we read articles and this is how we created it. But they never engage their intended audience. So then I say to them, so how am I supposed to work with you? Like, we're focused on Medicaid and women for this project. You've missed the mark here. So engaging and asking those questions and not assuming that you know is really important.
Yeah, and on that topic too, I think there was an earlier comment on another panel about helping moms to get to those appointments, or anyone who's struggling to get to those appointments, and what are the barriers to having them get there. So childcare, transportation, I think those are things that'll help with, especially in not employer-sponsored populations. I wanted to comment too on something that you said, Rick, about employers and how we're addressing the whole maternity. IBM has done some work actually in India and in Brazil so far, and we're now piloting it in the U.S. where we look at the whole experience from pregnancy to childbirth to return to work, and how do we make that as smooth as possible for the mom. And honestly, in an economy where we're struggling to find talent, it's incumbent upon employers to be doing this kind of thing, because it's the only way we're going to get moms back to the workforce. And of course, we want strong, healthy moms to come back to the workforce. And to your point about talking to people who are really accessing the system, we use a system very similar to what Melissa was talking about with her program, enterprise design thinking, or Agile, where we will bring a group of users into a room and talk about what are the pain points, what's working, what's not working. If you could design this any way you wanted to, how would you do it? And I think these kinds of forums help to do that, bringing stakeholders together, but there might even be something more formal where we talk about, okay, what are all the problems and how are we going to fix it together?
You know, I'll just say, before I was a child psychiatrist, I was a psychiatrist. And before I was a psychiatrist, I was a medical student. And in medical school, you take a lot of multiple choice tests. And your question was a complex one. I was wishing you could have phrased it as a multiple choice for me. But barring that, I'll say that there are a lot of barriers that we've been talking about. One of the things that we have is what we call the community support program. That was initially something we just did for people who bought insurance products on the exchanges, and we're probably in lower SES groups. We now offer that across our book of business, as we say, but it's exactly, you know, these kinds of things, figuring out, okay, someone needs help with bus fare to get to their appointment, or they actually need someone to babysit their kid, or sit with their elder parent so they can get to an appointment. How do we ensure that these basic kinds of needs that may seem unrelated to healthcare but intimately are ultimately get met so that they can have access to the care they need?
Thank you very much for that multi-layered question. That was a very helpful.
My name is Nakia, and just to put it out there, I'm a registered play therapist, and I hold a PPS in school counseling. So most of my career, I've been working with children. And as I've worked with children, I found that I need to work with the mothers, because as you mentioned, moms are the ones who tend to make decisions about care. And because I'm a woman of color, I tend to have a long wait list of other families of color, because they're really desperate for a familiar face, particularly one who specializes in play therapy and kind of like alternative interventions, because there's a lack of trust. The reason why I'm putting this out there is because I'm paneled already with most insurances. I'm on Cigna, Health Net, Medi-Cal, Medicaid. We accept it all. We're a group practice. We have a very diverse practice, and we have partnerships with domestic violence centers, with all these people out there who are working with children and families, because that's what I built my business on. Now, all that being said, we have no problem getting clients. We have no problem getting them into the door. My issue is I wasn't aware of any of these programs that are existent. And I just recently, in November, went and got my community-based doula certification and have actually incentivized my other therapists to go get that, because I see that's where we're going. So I'm trying to help our community already have access. But I need to know from you guys, how do I know about these programs? I know we get these middle-of-the-night faxes about things. I don't know if other providers get those.
The rates are cheap. The rates are cheaper in the middle of the night.
Oh, is that what's happening? I don't know, but sometimes as a director of my program, finding these faxes that I got at 2 a.m. in the morning is not our priority. So can I ask you, where am I going to get access to all of this wonderful stuff, like helping my clients get transportation to our center, helping them get childcare? Because right now we do provide childcare, but we charge them childcare while they're coming into services. I would love, like, hey, did you know Cigna does this? Did you know Health Net does this? So please speak to that for me. Thank you.
Yeah, that's a great takeaway for me, actually, because you know, all of these are what we would say customer-facing, but we want to let providers know as well. So let me chat with the provider folks at our table. Actually, we have one or two there, and find out what we have specific. I mean, the cheap and easy answer is give us a call and we'll tell you, but how would you even know to call? And that doesn't really help. So, yeah, right. So let me see what we have specifically available for providers. We do have provider newsletters, but I don't know actually when the last time is that we specifically talked about the community support program. Yeah, specifically for maternal health. So that is I used to know the folks who wrote those newsletters. Let me do a little bit of digging around, and thank you for that. That's a great takeaway.
I agree. I think that's a great question. We do have community-facing people. So we have 2 different sets of medical directors, and we do have medical directors that work directly with the people that we contract with in the community. And so those people are always available to you, and they have 1 per area, geographic area. So I think for Los Angeles, that would be 1 of 2 people. So I could also connect you to them, and they would be able to give you all of the information about what's available. And then we also have community-facing people who do that as well. So we do have in Los Angeles, we have Kristen Schlater, who's actually out in the community all the time talking to people and representing HealthNet and bringing things back and forth. So I think finding how to connect with those people, I don't know how, but I can get that information for you. It's different because what you're looking for is local, right? And the local people are out in the community all the time, and you should be able to access them. And it may be that the docs are interacting more with the larger practices and not the smaller practices. That's probably part of it. But certainly Kristen is out on the ground talking to people all the time.
Thank you. So I think we're right up at this.
One quick comment,
perfect.
if you don't mind.
Thank you, Joy.
I just wanted to comment on the employee assistance program that we've had conversations about, and Carol knows where I'm going to go with the statement. I struggle with employee assistance programs to provide mental health services. I think every company and every employee should have access to employee assistance for things like finding discounted childcare and those kinds of services. I think if we're paying premiums, society is paying premiums, we're paying premiums, our employers are paying healthcare premiums, that benefits should be available and accessible in network through our benefit plan. So I am not a big fan of EAP programs for this reason. I feel like it's a Band-Aid that's instead of investing in the broken system that we're Band-Aiding. It's a Band-Aid approach. So just wanted to make that comment. And
how would you approach solving that if it wasn't through an EAP?
Addressing what we addressed earlier today around ensuring network adequacy exists for mental health.
I love Joy, but I have to give a counterpoint to that. And I'm Laura Clapper, I work at Cigna, but I've worked at HealthNet and I've worked with Carol on the national account side. So I've seen EAP work really well for mental health services, and I was actually going to make a comment that providers need to use EAP more. It's kind of a hidden benefit. So if you're a provider seeing someone who needs mental health, and this doesn't help people who are uninsured or on Medicaid or something like that, but if for the 50% of moms who do have employer insurance, they have EAP, EAP has counselors that are available by phone right then, 24/7. So you could literally walk someone to the room next door, have them call the number and talk to a mental health counselor. That's how EAP works. And well, I mean, that's another conversation we can have. But what I like about EAP, there's no co-payment, no co-share. So in the life of high deductibles and things that have been put in place around employer insurance, and people worry about getting care, and we know from the data are delaying care because of high deductibles plans, they can get mental health today through their EAP. I just think it's a benefit, and for your household, right? So your mother-in-law who lives with you, who's 60 and doesn't have health insurance but is crying in her room, can use your EAP benefit. It's a benefit that is available where that's underutilized, and I just think we all need to think about it's there, and people aren't using it even though we're crying out for this kind of need. So
Joy, is what I'm hearing you say that EAP is a Band-Aid because it's not true mental health care? Because it's the same clinicians, but...
I mean we're paying healthcare premiums and the benefits should be available.
So, yeah, as far as counts... Yeah.
shouldn't have to go to an EAP program. The benefits are purchasing should work for us.
Okay, so we heard about mental health parity a little earlier today. One of the things I do is go out and do parity audits on health plans. What the law says is that mental health can't be any more stringent than medical, but it doesn't mean it can't go the other way. So health plans or customers can ask for zero deductible, no copay for mental health services within the benefit. I think it'll end up looking very much like the EAP because there's similar provider networks, but if an employer really is struggling with that, you can just take away the cost that you have to pay. You can't do it the other way. And it's something I would love to see happen too, because it's a barrier.
And I think employers are doing that.
The only, I think, a barrier to that is an employer who has a plan that's HSA compliant. So if you know about health savings accounts, the IRS gets involved and says that only certain things can be covered at 100% before you've met the deductible. We've made great strides on that list of things that can be covered. The list just expanded last year. Unfortunately, mental health is not one of them.
It's changed.
Yeah.
Well, thank you, everyone. This was a really robust conversation, and thank you to all of you for hanging in there a little bit after 5. Do we want to maybe one very last time? We can.
Do more. Good. Thank you.
Thank you, Joy, and thank you for everyone on this panel.
Thank you, Karen. That was great.